life in balance, in health, and in patience. So welcome on behalf of Bridge the Gap, Miss Lane, who was hiding somewhere, on her behalf, on the behalf of the entire board of directors with Bridge the Gap, and to all of the sponsors, to AstraZeneca, to Merck, to Heal Collaborative. We welcome you. We welcome you. So please feel free, get everything you need. So when you leave here, you can be empowered. Amen. Amen. So once again, say it with me. Great morning. All right.
Thank you very much. I'd like to have some welcoming remarks if we can. First, we're going to have Mr. Howard Mosby. Well, I'll introduce him a little more thoroughly as later on in the program, but Mr. Mosby is a co-founder and corporate treasurer of Heal Collaborative. Howard. We'll wait, sir. Good morning. This is the, hey, this is the day that the Lord has made, and what? Y'all feel like y'all rejoicing when y'all say it like that? This is the day that the Lord has made, and that's what I'm talking about. And this is what this is about. Say it. So this is really about how we bring information to the community so that you can be healthy, that you can rejoice and be glad in the work that the Lord would have you do in your communities. My name is Howard Mosby. I'm one of the founders for Heal Collaborative. We are glad to be here today in Duval County. Uh, Duval. Otherwise, I bring my Atlanta Falcons jacket up here, and we can do this over again. Nothing? Okay. No, thank you all. Actually, it's been great. Jacksonville is a great city. I am so happy to be here. This is a Chamber of Commerce day. It is beautiful outside. It is beautiful inside with all of you all here. We're glad to be here today. We're going to put on a great program for you all. It's a lot for you to pick up on, but this is really about your health. If you are sick, you do not work. If you are sick, you don't tithe. If you are sick, you can enjoy the benefit of what it means to live the best life, the abundant life. And so we're here to give you information to help you to navigate this health situation. I'm glad to be here. Thank you all for telling me to shut up, I guess, because the sound keeps coming off. Thank you for having us. And with that, I will turn this back over to Dr. Tuckson. Thank you. Several choices here. Before we bring up Pastor Lane back up again in a minute, we're going to continue with the welcomes and I'll bring up Mr. Josh Spagnola, please. Josh is a director of regulatory strategy and corporate and state government affairs with AstraZeneca, one of the sponsors of our program.
Appreciate it. Good morning. All right. I'm very excited to be here. It's a great facility, great. Doing it to me too. Really appreciate all the work that Bridge the Gap does here in the community. Went and walked through the garden earlier. Healthcare company, so we focus on all things health, and good healthcare starts with a lot that's going on in that garden and a lot that Bridge the Gap is doing. So just appreciate everything that you all are doing and the fact that you're willing to host us, and want to thank all of you for coming today. It shows that you care. It shows that this topic is important, and it shows that you're willing to invest in your care. You know, healthcare is very complex, unnecessarily so in many instances, and we're here to try to bridge the gap, bring some information to you, understand what the risk factors are for certain conditions, and then also, very importantly, try to identify where there are gaps. Across the state of Florida and in this community, there are a lot of times where there are gaps, there are issues getting access to care, and it starts with you all getting the information you need and getting informed. And then from there, we can go all the way up and find the gaps and come up with solutions together on how to bridge that. Today, we're going to talk about lung health, which is really important, both on the lung cancer side and the COPD side. There's so much overlap. There are so many services out there, but there are so many gaps that we need to address. And we just appreciate you all coming today and willing to participate. A lot of the solutions start at events like this and go up instead of coming from the top down. So this is really important. We're happy to be here. Thank you so much.
Ms. Yvonne Lane, if you come on down, please. We'll have welcome remarks from Ms. Yvonne Lane, and she is, of course, well known to everyone here. She's the executive director of Bridge the Gap.
Good morning, which is a wonderful, great morning. And the reason why it's so great because you are here. We do thank you, and we thank you all for being here, coming out on this great morning, for making it a greater morning. And we want to welcome you to today to learn, to get all you can from our presenters as they give us what we need to live a better, healthy, and wealthy life. So let us thank God. I also thank Him more for our presenters. Let's give a hand to our presenters today that will be sharing their wisdom and knowledge with us today. Isn't that a blessing? And then for our sponsor of this great event, Heal Collaborative. Let's give them a hand. And we want you to know, when I say we, I'm speaking for Bridge the Gap and Heal Collaborative. This is just the beginning of the beginning. And we will be back next year to do a greater. Welcome you.
Thank you, sir. I'd like to bring again Pastor Lane up to give us a prayer.
If we can all just bow our heads. Father God, we thank you for this opportunity. God, that you woke us up this morning. God, that you touched us with the mind to be in this place at the right time, at the right moment. And so, God, if we didn't tell you this morning, we just tell you thank you for your goodness. God, we thank you, God, that the sun is shining, the weather is great, and we believe that that is just a sign, a confirmation that you are well pleased with the event on today. Now, God, we ask in the name of Jesus that every presenter that shall mount this platform, God, that the words that will come out of their mouth, the information that they will share will fall on good ground. That we, your people, that we hear that information, we would take it and apply it to our lives and pass it on to others. God, I pray now for Heal Collaborative, the visionaries of Heal Collaborative. I thank you for doors that shall open, increase and expansion that shall come because of their obedience and their heart to want to see your people live healthier. We thank you for AstraZeneca. We thank you for Merck. God, we thank you, God, an increase shall even come to them because of their heart for your people. And so, God, we yield everything over to you now. We even yield the sound system over to you now. God, we come against any distractions and any hindrances, God, because what you've ordained, you shall manifest your glory. And so we thank you in advance for healing and transformation that is taking place right now in the hearts of every individual. And we will give you an advance praise because we know that you have placed your stamp of approval on this event and nothing but goodness shall come after this. And so, God, we tell you thank you and we bless you now. And I pray in advance that those that will be traveling back to their destination, that you would give them safe travel in the name of Jesus. And we thank you for it in Jesus' name. I need everybody to put your hands together and let's bless God because it's already done. Come on and bless the Lord. You already know what Bridge the Gap is about. Hallelujah. Come on, we can clap better than that. Yes, God is good. And we thank and praise Him.
As I stated in the beginning, this program is about lung health. So often when we think about lung health, we only think about cancer. Remember, we're talking about other things affecting lungs, in this case, most notably COPD. So we're going to be talking about all of that today, getting into, as I said, also about diagnosis, treatment, and other issues. To get things started off, our first speaker is Dr. Eric Flanow. Dr. Flanow is a graduate of the University of Texas Health in Houston at the McGovern Medical School there. He completed residency in internal medicine at the UT Health Science Center in Houston and a fellowship in pulmonary and critical care medicine at the University of Texas Health Science Center in Houston and the MD Anderson Cancer Center. He is currently an associate professor in the Department of Medicine at the Morehouse School of Medicine in Atlanta, Georgia, and he's the chief and director of pulmonary and critical care and interventional pulmonary medicine at Grady Hospital in Atlanta. He's also the director of the Georgia Cancer Center Advanced Diagnostic and Interventional Pulmonary Service and the director of the Lung Nodule Clinic at Grady Hospital. In addition, and we'll make comment about this again with one of our next speaker, but during 2020, during the height of the COVID pandemic, efforts that Dr. Flanow took in order to care for those with COVID in the Atlanta area garnered him a top doctor award by his peers and recognized for his work there in COVID-19. Today, Dr. Flanow will speak to us on what is lung cancer, how is lung cancer diagnosed. Dr. Flanow.
Thank you. And thank all of you for coming out this morning. It's a nice day. You could probably doing some other better things, but thanks for coming out. Let me see if this works here. Okay, so here's my task. I need to tell you guys all about lung cancer in the next 20 minutes, 25 minutes or so, 30 minutes, which is going to be a little bit of a challenge. But I just want to give you an understanding because it's important for everybody to know what we're talking about when we talk about cancer and how it impacts us with a lot of the healthcare disparities. So first of all, when we talk about disparities, these inequalities with healthcare amongst different populations, whether it's socioeconomic, racial, or across the board is all, I like to think of it in two different categories. One main category is health. And when we talk about health, we need to think about the environmental things that we're exposed to and the people's biology, right? Because everybody knows we're a little bit different in different ways, okay? So what they're exposed to in terms of, atmosphere, pollution, smoking, chemicals, and then how that impacts different different people's bodies, how they respond to it. And that makes up your health. And then the other part is the health care and what's available to you. Is there opportunities for early detection? Are there opportunities for the system to help you get through that? And all of those merge to either develop into one coherent system or to have disparities and differences in how people are affected by it. So what exactly is lung cancer? I want to tell you, any cancer is where you have a normal cell and then for some reason there's a change. There's a genetic change that makes that cell do something that you wouldn't think is that bad. It makes it divide, but it divides and multiplies out of control. And you go from 1 cell to 2 cells, you go from 2 cells to 4 cells, 4 to 8 and on till you get this big cluster of cells that starts taking over the organ that it starts from. So that cell, that normal cell, it could be a prostate cell, it could be a breast cell, it could be a colon cell. Today we're talking about lung. So think of it in terms of lung cancers. But when it gets to that malignant cancer, this thing that spreads, that's when it starts to have a problem because it's in this cycle where it takes over the body. Okay, so when we talk about cancer, and I think if you listen to the videos a little bit earlier, there were 2 types that they were talking about. Somebody's talking about small cell and non-small cell. So there are 2 major types, and I want to give you an understanding about how they differ, okay? So one of them is small cell. Small cell is just like that. That's an actual slide of it. Each little purple dot that you see there is a cancer cell. So the cells are small. They grow very fast and they spread very fast. This is a more aggressive type of cancer. And by that, it means it spreads faster and people survive less. And so it limits our ability to treat and get ahead of it and get to cure. It's closely related to smoking. Okay. The other type, because we doctors are not good at naming things, are ones that have bigger cells. So again, each purple dot you see there, that's a cancer cell. You see they're a lot bigger, okay? They're larger cells. It grows a little bit smaller. It spreads a little bit slower. And there's more causes, not just smoking, but there could be things like asbestos. There could be things like chemical exposures or environmental things. But that's the two major types. And I want you to keep those in mind, because if you know somebody that's had lung cancer, or if you have had it yourself, these are the things you have to understand about it for you to understand why treatment is important from that. And then the other question we ask is, well, why is lung cancer bad for Blacks and African Americans? Well, the reason is Blacks have a higher death rate from smoking despite smoking, or from lung cancer, despite smoking equally as other races. So I want you to think about that. You can smoke the same as somebody else, but you're more likely to die from lung cancer because of that, just because of race. They're less likely to get screened and early detection, which puts you behind the curve in terms of being able to get better treatment, which means you're more likely to get diagnosed later. And in some cases, you're less likely to get any treatment at all. So to give you an idea about how bad it is for African Americans, these are two characters. On the upper level, they're talking about the number of new cases of any type of cancer we expect to see for African Americans this year, whether it is men or women. And on the lower part, you're looking at the amount of deaths we need to see from each specific cancer. So if we look at number one for men and number one for women, number one is prostate cancer for men. And for women, it's breast cancer. For men, lung cancer is about 3 times, prostate cancer is going to be about 3 times as much this year we expect to see over lung cancer. But if you look at what's killing them, lung cancer jumps to number one. So you have 3 times as much prostate cancer, right? But what's going to kill them is lung cancer. For women, it's about the same. You have about 3 times as much breast cancer this year. But what's going to kill them? Now, breast cancer still is number one, but the difference is about 400 or 500. So it's about the same. So this tells you, even though you have 3 times as much as other type of cancers for both men and women, lung cancer is still jumping up to be a big killer there. And it's the number one solid tumor killer of all people. And when I talk to you a little bit about the differences between smoking and different races and the amount of lung cancer that develops, this is an example I want to show you. So on the right-hand side, you're looking at the smoking prevalence. We have a category for African Americans, we have a category for whites, and we have a category for Native Americans. Men are in yellow, women are in orange. And if you look at African Americans, the smoking rate is about 25% for men, 23% for white men, and about 42% for Native Americans. And then the difference here between African Americans and whites in terms of smoking, and even for women, 18 and 20, those are about the same smoking rates. So if we jump over and we look at the incidence rates, and they look at how many cases per 100,000, don't worry about that, just look at the numbers, 74 versus 64. So there's a 10-point difference, right? So even though you smoke about the same, cancer rates are higher. Right. So this tells you something what I was saying earlier about the biology. There's something about the biology in African Americans that changes and makes them have worse effects from from tobacco smoking. And if you really want to see the example of it, take a look at the Native Americans, right? Native American men, 42% smoke, right? But look at the tobacco rate. They're almost 30 points less. So it's not okay for them to go out and smoke. I wouldn't suggest that. But the reality is there's something different about the biology that impacts different populations. And until we understand that, then we can't start to make changes to impact a lot. Okay. So if we think about causes across the board, we will talk about smoking, right? Because it is the number one cause. About 95% of people who develop lung cancer, it's linked to smoking. But there are other things. Radon. So has anybody heard of radon here? A few people? So here's what radon is, and it's really important to understand this. Radon is the number one cause of lung cancer in people who have never smoked in the United States. Radon is a radioactive product. It is a breakdown of either radon or uranium. It's in the soils, especially if you live near mines, if you live near granite, like we have Stone Mountain in Georgia. The radon rates are high there. It doesn't have a color. It doesn't have a taste. It doesn't have a smell. It comes up from the grounds. And if you have a basement or you have vaulted ceilings, they can concentrate in the houses. And in Georgia, I know specifically, if you're buying a house, it has to be tested for radon. But here in Florida, of the houses that are tested, about 12% of them have levels that are above the safety levels that the EPA has, right? Randomly. So if you know somebody that says, oh, I never smoked, but they, I had a family member that developed lung cancer. They never smoked. Or somebody else down the street did. You might not think that these houses in those neighborhoods might need to be tested for radon. And I think most communities, and you can look up these maps online and find out what your neighborhood's radon levels are, because the governments know this. But who do you think lives in these populations, in these houses, in these communities, right? Yes, because the houses are cheaper, because nobody else that knows it's there is going to buy it. All right. So here's the other big thing. What I've learned over years, seeing patients, is I no longer just have to ask, how long have you smoked? How much do you smoke? What do we have to ask? What do you smoke, right? Because this is, I think, a lot of this, we don't really understand what everything that we're putting into our lungs and how that impacts our risk of developing lung cancer or other lung diseases. So, everybody talks about nicotine with cigarettes, right? Nicotine and nicotine. Nicotine's not what's causing the lung cancer, okay? It's about the 6,000 other chemicals that are released, from the formaldehydes, the arsenics, and everything else that is mixed into those chemicals that burn and you inhale. That's what's causing the cancer, and that's how it develops. But the nicotine is the part that keeps you addicted to it, okay? So nicotine, if it were a new drug coming out on the market today, the FDA would have a problem with it, right? It is more addictive than most other substances we know. The only two that we know are more addictive are cocaine and heroin, right? But those aren't legal, right? But the nicotine is in the cigarettes. It's so addictive that it's tightly regulated to every cigarette is measured, and it's kept down about 8 milligrams of nicotine per cigarette. So we can measure that, okay? So when you think about it, we can compare, because I had one patient, he's 34 years old, he had stage 4 cancer. I asked him, I said, well, how much do you smoke? He says, Doc, I only smoke 4 a day. I said, 4 what? He said, 4 Black and Milds. I said, okay, so those are those little cigars. You guys have seen those, right? So those small cigars have about 100 milligrams of nicotine in them, all right? That equivalent is about 12 cigarettes. He didn't understand that, but I said, do you understand you're more than a 2-pack-a-day smoker, right? That's the equivalent there. And then, you see people that watch, they're going to go out to the cigar bar, right? Or they watch a game, they're going to smoke a cigar. Those have, the large ones, they have 200 milligrams, right? That's 1.25 packs in one sitting. And you think about, okay, so one time, okay, man, but it's that social acceptance of it and that amount of nicotine that gets into their systems that keeps them coming back from that. But the companies knew this, right? And they advertise. They advertise specifically to populations, and especially African-American populations. And if you don't believe me, ask yourself, why did they name it Black and Mild? Okay. So we've seen a lot of the electronic cigarettes, the Juul pods, the puff bars, the certain pods. Okay, so we know 1 pack of cigarette, how many cigarettes? 20, great. I went to high school, I was giving this talk, I asked them and nobody knew the answer, and I was happy that they didn't know the answer. Right, so 20 cigarettes and 1 pack of cigarettes. Okay, so these Juul pods, because you see people drive around and they take a big puff and there's this big plume of smoke that comes out and whatever else. One of those is equivalent to about 41 cigarettes, okay? And the problem that I'm having, especially with the puff bars that are now menthol flavor, which is supposed to make it smoother so you don't feel the bad effects of it and discourages you from keep buying them, that starts jumping you up to about 50 cigarettes. So you can see how this nicotine amount is getting in one setting. Some people go through a couple of those things a day. And you get to these certain ones. This is the really bad one. It's 90 cigarettes worth in one of those. And people are buying 2 of those because the companies know once you get on that, and once that nicotine gets worked into your system and you're addicted to it, when those things become too expensive, you're just going to go out and buy some cigarettes. It's planned. And there's people of varying ages. So I have, over time, some of the advertisements and how it's been impacted and what they've known and how they've been targeting, right? I like to think that I'm close to the, the newer ones because, I would like to stay young. But if you look at this, for every one advertisement that had a Caucasian person in it, there were 10 that had African Americans in it. This was targeted advertising to specific populations. And now there's whole manuals on how to work towards the vaping market in the United States. Okay? And it's targeted to the young people, showing vibrant, pretty, engaged people to encourage them to keep smoking. Hookah bars, right? This is the new trend. So this is my thing with hookah bars. I just don't even like it from the aesthetic part of it, right? If a friend hands me a cup with a straw in it and they say, here, take a sip, I'm looking at the straw like I don't know where your mouth is, right? But what's happening now is they'll go into a hookah bar, they'll rent out a section, 5 or 6 of them will sit around, they'll bring it out and they'll pass this little thing. There's, everybody's bad breath. You can see the smoke all around. They'll take a 1-hour session, right? And they're passing this around. That 1-hour session, they're getting about 200 puffs. Yeah, it is nasty. I'm not going there, right? That one session is equivalent to about 100 cigarettes in that one setting. So now is that one setting going to get them addicted or not? No. But you know what the other part is that the social acceptability of that is what's also giving back. Because right now you have young people whose minds are still developing, right? And you're incorporating an addictive substance into them, and it's socially acceptable to them. And it's legal. So that's where the problem comes. Because once you get addicted to something, it's hard to break from it. So, yeah, we got this one. So the problem with cannabis, the problem with marijuana is in the past, we didn't know that there was a direct link to lung cancer and smoking marijuana. But now studies have shown that there is. And what this is like if you are a heavy marijuana user in the study, that you had a 2-fold risk of developing lung cancer. So what's heavy? Anybody want to know? Yeah. 50 times in a lifetime. Not in a day, not in a week, because we know some people. 50 times in a lifetime. I got some patients that they have 50 times in a week is nothing to them. So that's a heavy user. So we know there's a risk for it. Okay. So that brings us to, with all of these things, not only do we need to change some of these behaviors that impact our likelihood of developing, we also need to know, how do we find lung cancer early? How do we screen for lung cancer, and why is it important? Okay. So it is important because with lung cancer, and I'll tell you why it happens this way. With lung cancer, by the time you have your cough, by the time you're short of breath, or you've gone to the doctor and they started treating a pneumonia that doesn't go away and it's in the same spot, or you're coughing up blood, or you're losing weight, by the time you have any of those symptoms, most of the times those are either stage 3 or stage 4, right? So the goal is with screening is that we want to find lung cancer before you have symptoms, before it's bad, okay? And with the screening, and I'll give you a little anatomy lesson. So in your lungs, on the edge of your lung, there's a lot of nerve fibers, right? If you ever known somebody that's fractured or bruised a rib or something like that, it hurts, right? So there's a lot of nerve fibers. Inside your lungs, in your airways, there's a lot of nerve fibers, right? So you have the cough, something triggers it, you have the cough. But in the tissue, out in the tissue, there's not very many at all. And that's usually where lung cancer develops. So when that happens, it gets a head start because you may not know it's there. So we have to find people who are at risk for it and start looking for it before you start having those symptoms. And when we find them early and you get it detected by screening, you have a 20 to 25% less chance of dying of lung cancer by screening. So this is important. If you know somebody, or if you are somebody that is between the ages of 50 to 80, and you're going to hear a little bit more about this later, so I won't spend a lot of time, but between the ages of 50 to 80, and you have smoked what we classify as a 20-pack year or more history. So what that means is if you smoke 1 pack a day and you've done that for 20 years, you're a 20-pack year history, okay? If you smoke 2 packs a day for 10 years, 20-pack year history, right? If you're 20 or more and you're between 50 and 80 and you smoked any time in the last 15 years, then perhaps you need to get screened. Or if you know somebody, encourage them to get screened because it can help them catch it early and save a life, okay? So does it actually help them save a life? Yes, because if we look at the distribution of lung cancer, when you find it, and we can either find it when it's localized or early in one spot, or if it's regional, it's kind of in the lungs but has some lymph nodes, or it has spread all over. So we have whites and blue, blacks and red. Whites are more likely to have it found early. Okay? In the middle, it's about the same. African Americans are more likely to have it found late when it's spread to other places, which means your likelihood of getting a cure is less. Okay? And specifically in Florida, we have in the dark blue are whites, and the light blue are African Americans. And if we look at how many are being diagnosed early, more whites are likely to be diagnosed early, almost 4 to 5% more, which means they're more likely to get the curative treatment, which is surgery. And African Americans are more likely to not get any treatment at all. So if you happen to know somebody that is diagnosed with lung cancer, or yourself are, I needed to give you this understanding about why it's important to get and seek out treatment early. Okay? So we have what we call a doubling time. And it's how fast the cells will go from 1 cell to 2 cells, or 2 cells to 4 cells. But think of it like this. How fast does it go from the size of 1 grape to 2 grapes, 2 grapes to 4 grapes? And that's what we call our doubling time. So for this non-small cell one, it takes about 60 days. 60 to 90 days. So think about this. When you get this diagnosis, a lot of people say, I don't like that diagnosis, so I'm going to go somewhere else. I'm going to get a second opinion, okay? Then that means, okay, you have to leave there, and then you have to get another appointment with someone, which is about another week or so. Then they have to get all the records, which is about another week or so, and then they get other scans, which is about another week or so, and they might do another biopsy, and before you know it, this thing has doubled in size, right? So it's important to go with you have and get sought out. A lot of times we delay things. Once you have that diagnosis, we need to get moving on it. When I tell somebody, we're moving from you, here's your next appointment, here's the next screening scan. So why it's especially important, because this is the one you can cure, right? If we catch it early and we get it out with surgery, we're done. If it doesn't work, then you'll go through chemotherapy or other options that'll help us. But catching it early is actually better. Now, the one that I said is bad one, the small cell one, 1 month. So again, think about, well, I don't like that diagnosis. Okay, go get you get 2 weeks, 3 weeks down before you see somebody and get the next thing. It's already doubled in size and had the opportunity to spread. So the thing is, when that diagnosis is there, it's really important to get that follow-up, get your support group with you. Because this is the most aggressive. Only about 5 to 10% are still alive in 5 years when you have that diagnosis. Despite treatment, if you have already spread to different parts of the body, average lifespan, even with treatment, is only about a year. Okay, and only 10%, even with treatment, are still alive after a year, after 2 years of treatment. So to attack some of these disparities, we have to understand all of these factors that impact it, from early detection to system factors to your health care. and the environmental factors that we either are exposed to or that we get exposed to. But the other thing to do, to look at it, how do we decrease these disparities? We know that early detection, you can decrease or improve your survival by about 20 to 30%. So knowing what to do, how to get the screening, who would benefit from the screening can actually help save the life. It'll decrease your mortality by about 20%. And we can't make any changes in decreasing these disparities if we don't know what to do, if we don't have that education, right? That health literacy, knowing what we're talking about, knowing what to look for. But when you do have it, things get better by about 25%. So the other big thing, you cannot talk about improving things without having to bring in prevention. And this is a study they did in 2022. They looked at middle school. I have another one for high school, but it doesn't get any better than this. It actually gets worse. These are middle school students, any of them using any tobacco product. And the average is about 5%. This is what I found interesting. Girls were using stuff more than the guys in this study. But it started out with the electronic cigarettes and the cigarettes, and then it just went up. And the companies knew this because they had to ban them from giving, candy flavored and fruit flavored e-cigarettes. So they knew exactly what they were doing, because once you get those young minds that continue to develop until they're 25 years old, and you start getting an addictive substance and get it break into their circuitry in their brains, then it's harder for them to quit. But here's the other thing. We can't tell our kids not to do something if they see us doing it. Exactly. The other thing is studies, and we can talk about this a little bit more if we get into discussion. A lot of times with research studies that people, let's just say, there's not a good history with African Americans in research studies. It's led to a lot of distrust. Okay. But what also came out of that is changes in how research is done, so that there's no longer people feel like they're a guinea pig or they're just going to get, placebo, sugar pills. They're actually getting some treatment that's safely regulated and whatever else. But when we don't participate in some of these studies, then we don't know how treatment affects us, because I've already shown you that the biology is different. So treatments and diagnosis and side effects aren't measured to impact us. But one of the benefits about being a part of a study is that you get newer treatments. You have opportunity for newer treatments. If you don't have enough funding, you're underinsured, that a lot of your treatment might be free and the follow-up is free. And it could actually help to save your life. So this is something we need to think about, because only about 6% of cancer studies have African Americans in it. So we're not being represented. And if we don't represent, we don't know how things work with us. Thank you for your time.
Thank you very much, Dr. Flanagan. I want to remind you that if there are any questions that you have, please write them down as you think of them. And because at the end of when all of our speakers have had their chance to speak, then we're going to take questions again. Our next speaker is Dr. Jennifer Fulton. Dr. Fulton, as you will see, has started off in the north and worked her way steadily south. I hope you finally got warm, Dr. Fulton. She graduated from the University of Rochester School of Medicine and Dentistry, then completed a residency in internal medicine at the University of Virginia Medical Center, followed by a fellowship in pulmonary disease and critical care medicine at the University of Alabama Medical Center. As you see, she starts high and comes down south. More importantly, though, in 2020, Dr. Fulton was recognized by the Florida Times Union with the Eve of the Moment Award. For those of you who may not know what this is, the Florida Times Union, approximately about 54 years ago, started an award to recognize outstanding females in various different disciplines. And she was recognized for her outstanding work, along with her colleagues at Baptist Medical Center, for her work with COVID-19, during that COVID-19 crisis. And I applaud you, ma'am. Today, Dr. Fulton will be speaking to us about what is chronic obstructive pulmonary disease and how is it diagnosed. Dr. Fulton.
Thank you, everybody, for being here, and thank you for inviting me. COPD, when I was in training, I have to say, was a little boring because we didn't have much we could do for it. But times have changed. I've gotten older, and the disease treatment has gotten much, much better. And so we need to understand what COPD is and what we can do to help people with COPD. And I need to tell you, you don't need to die from COPD and you don't need to be disabled from COPD if we can get you treated early and get you on the right path. People have a huge misunderstanding of what COPD is. COPD stands for chronic obstructive pulmonary disease. What does chronic mean? It means all the time, right? Do you know that COPD is a sister disease to asthma? They are both breathing out diseases. The difference between asthma and COPD is that asthma gets better and worse and better and worse, whereas COPD is just chronic all the time. But if you are a COPDer, you can also have components of asthma, and undertreated asthma will eventually look like COPD. So the diseases are very, very, very close. And so we need to understand that because especially in the African American community, asthma gets undertreated. And if you don't get your asthma treated as a young person, you're going to get COPD as an older person. And we don't have to have that. So we're going to talk about how we understand COPD. What causes COPD? I already told you one thing, right? Undertreated asthma causes COPD. But most importantly, and you've heard this from my colleague that just spoke in front of me, tobacco. And it's all forms of tobacco, just like we just heard. It's not just cigarettes. It's cigars, it's marijuana, and it's the Juuls and the e-cigarettes and all of that. They can all cause COPD. And what's really interesting is that now that we can do studies on it, we can see that the COPD or the emphysema, which are the way the airways change in the lungs, that is caused by regular tobacco is different than this emphysema that is caused by marijuana. When you smoke marijuana, your emphysema palisades or lines up in a tight line all the way around the edge of the lung. Whereas when you smoke regular tobacco, it's more distributed throughout. So there's a difference in what we inhale. But do you remember in the 1980s, stop, drop, and roll? Like, okay, anything heated that you smoke, put in your lungs is bad. So just if it's heated and it goes in your lungs, don't put it in there. Secondhand smoke counts. So I will tell you, one of my big jobs is to get people to stop smoking because that is the most important way you can take control of your health. And everybody has their own button. So what is the button for you? A lot of people, it's not their own health because we take care of others first, right? So for one of my patients, I spent hours over years speaking to her about her tobacco use. It wasn't until she accidentally burned her granddaughter with her cigarette that was her moment. And I see that with every patient, that there is a moment that they decide, this is it. And so what you need to think about if you're struggling to quit smoking is, what is your button? What is it going to take for you, because we all have different buttons, to stop smoking? And people have said, well, I've tried it before and I just can't do it. Well, do you know that every time you fail, your next opportunity, you're more likely to succeed? So don't think about it as I failed before, I can't do it. Think about it, I just set myself up for being more likely to do it the next time. So I encourage you all, if you're smoking or if you know somebody who smokes, to think about quitting. Florida Quits is an amazing program that everybody here has access to. They encourage you. You can get free nicotine replacement. It's an amazing program. And why does secondhand smoke count? Because it's not just you that's inhaling that tobacco or marijuana smoke. It's your grandkids. It's your kids. It's anybody who's around you while you're smoking. So if you won't do it for yourself, do it for the people around you. Genetics. Genetics are also very important in COPD. Some people can, just like we just heard in lung cancer, some people can smoke a lot and not get COPD. Some people just take a little bit. There is a particular genetic disorder called alpha-1 antitrypsin that even people who have never smoked can get COPD. So if you know somebody who said, I never smoked, but I have COPD, they maybe have that alpha-1 antitrypsin. And now we have genetic replacement for it. And exposures. So in this country, tobacco is the #1 cause of COPD. But in other countries, it can be, like in China, smog, the pollution in the air is a very important factor. So those people who live in LA who are always under that smog, they have higher risk factors. So pollutants are a risk factor. Here in Jacksonville, we get all of the debris that comes down the coast. So we live just south of all of those paper mills, and we live just south of a lot of naval bases. So all of the stuff that they're putting into the air comes to Jacksonville, and we live in a little bite. Have you ever looked at a map and looked at where Jacksonville sits? There's a little bite in the coast. So when the wind comes down, it doesn't keep going. It kind of gets stuck right here over Jacksonville. So the environment we live in can help promote disease progression. All right. So what are the symptoms of shortness of COPD? #1 is shortness of breath. So people feel like they can't quite get that big breath of air. Cough. Lots of cough, typically wet cough, but it can be any kind of cough. Recurrent infections. So patients come to me and they're like, Doc, I just get pneumonia 3 times a year, or I get bronchitis all the time. It may not actually be pneumonia or bronchitis. It may be these exacerbations of COPD. Wheezing. So I hear this rattle, I hear this wheeze in my chest, and exercise intolerance. So you're fine when you're sitting there, but when you get up and try to do something, can't quite get your breath, you have to sit down and stop. You recover, but it happens again. I will tell you that people present late with COPD because they find excuses. The first symptom is going to be that exercise intolerance, but I'm getting older. Oh, I've gained weight. We all make excuses for why we're feeling the way we are. And I empower you to stop making the excuses and go get evaluated, because the only way we can diagnose this is through testing. And just because you're short of breath and a smoker does not mean you have COPD. Do you know that there's another disease very highly associated with tobacco smoke that causes shortness of breath? Coronary artery disease. So your symptoms of shortness of breath may not be from COPD. They may be from another disease entirely that is also very treatable. But the only way we can distinguish them is to evaluate. And if you don't come early for evaluations, then we're losing time. So just briefly on anatomy, this on the left here is the healthy lung, on the right is a COPD lung. So the airways, the main airways here, lead to these smaller airways that we call bronchioles. And those bronchioles then eventually lead to the alveoli, or the alveolus, which are the tiny air sacs where oxygen goes, or air goes in, and carbon dioxide goes out. So we exchange gas in those alveoli. So, do you know air that we breathe is only 21% oxygen? Did you know that? It's only 21%. So we're inhaling a lot of other gases and pollutants and all of that every time we breathe in. But we're only taking in 21% oxygen. When you have COPD, those bronchioles get inflamed. They produce sputum. There is a cell on every single airway in our lungs called goblet cells. And goblet cells only job in life is to make sputum. Why? We want an interaction between us and the outside world. Have you ever been in a really cold place where you take a deep breath and it hurts? That's because that mucosa is supposed to be moist and wet. When it gets dried out, it hurts. So those goblet cells are there to make this protective mucus so if we inhale particles, it gets stuck in the mucus and not in the lung tissue. But it also helps to coat our airways and makes it comfortable to breathe. When we have COPD or asthma, those airways get inflamed, and the goblet cells run home to mama response is make more. So the wet cough that people with asthma or COPD have, it's not always infection. More commonly, it's because their disease is exacerbating. Exacerbating means getting worse. You can have acute exacerbations, meaning you get exposed to a virus or you get exposed to something you're allergic to. You get acute worsening. And then you can have chronic exacerbations where you kind of have this slow progression. So that in one, because those airways are swollen and now blocked with mucus, makes it hard to breathe. In addition to that, these alveoli, which are the tiny little air sacs that exchange gas, so oxygen into the blood, carbon dioxide out, get dilated. And because of that, there's not as much surface area to do that gas exchange. And because of that dilation, they don't act properly. So you have more inflammation and harder to get the air where they're supposed to be going. And once it gets there, that alveoli isn't working as well. So it's a kind of a double whammy, okay? And that's what COPD, and honestly, COPD, the difference between COPD and asthma is asthma, they have all that stuff in the bronchioles, but their alveoli are normal. Whereas in COPD, the alveoli get destroyed. Why would untreated asthma eventually look like COPD? Because if you have untreated asthma, you're trapping all that air in it and forcing those alveoli to expand to accommodate all that trapped air. So eventually, they're going to look like this. How do we diagnose COPD? I already told you it's not by history. I can't ask you good questions and say, you got COPD. I can't listen to you and say, I think you got COPD, because COPD and asthma are going to sound exactly the same. The only way I can diagnose you with COPD is to do a pulmonary function test or a lung function test. It's a very simple test. All we do is we hook you up to a mouthpiece and we tell you to do some breathing exercise. By looking at those breathing exercises, I can tell you whether you have obstruction or difficulty getting air out. This is where it gets tricky to differentiate between COPD and asthma, because the first time you come into my office and I do a pulmonary function test and you say, well, I have good days and I have bad days and I'm not really sure, and I do a pulmonary function test, that initial pulmonary function test, if it shows that you're having difficulty getting air out, we're going to call it COPD. But if you were in the midst of an asthma exacerbation, it would look exactly the same way. So I need to make sure that we have to differentiate between asthma and COPD, and we have to look at the testing. The most important other reason we need to do testing is because if you tell me I'm short of breath and I have COPD, and you don't have, or I'm short of breath and I smoke, and you don't have COPD, I need to get you evaluated for heart disease, because that is the other mimic of these symptoms that gets underdiagnosed. So when we talk about COPD and lung function, we talk about staging. Just like in cancer, there's 4 stages: mild, moderate, severe, and very severe. I know we're very clever in how we name these things. So those 4 stages is how we determine your risk of worsening disease, your risk of exacerbations or these acute worsenings, and your risk for cancer. Because COPD and cancer are connected. Because think about it, if your airways are getting destroyed, do you think those cells are going to be normal? So they're higher risk for conversion to cancer cells. So we want to make sure also when you get diagnosed with COPD that you also start cancer screening. That's the other reason it's very important to know if you have COPD, because it will say you have higher risk for cancer. Let's get you screened. Did I just do something? Okay. So we have to look at the PFTs, and we have to determine what your disease is. Is it COPD, and how advanced is it? And then we need to ask, what do we need to do for it? How do we treat COPD? Well, we treat COPD with inhaled medications. What's really great about the lungs is we can deliver drugs right to where it needs to work. We can just inhale them. It's a very clever delivery system that God worked out for us. So we can give people inhalers. Those inhalers, there are a lot of them out there now. I will tell you, when I started training many decades ago, I had 2 inhalers. When I was a fellow, they came out with a 3rd one, and we thought that was like life-changing. Now there are 21 different kinds of inhalers that I can use to treat my patients with COPD. Also, we have discovered that there are cells in our body called eosinophils. Eosinophils are the white cell that is made to attack parasites. But here in the United States, we don't have a whole lot of parasites, right? So these guys get bored and they start causing mischief. And what they do is cause inflammation. Well, I already told you, if the lungs are inflamed in COPD. So what happens if you have other cells running around in there causing inflammation? It's going to make the COPD worse. So now we have an understanding that if you have these eosinophils, you need more aggressive treatment for your COPD. For exacerbation. So what happens during an exacerbation? When you have an exacerbation, whether it's because you, again, get exposed to a virus or some kind of noxious chemical or something you're allergic to, you have an acute worsening of your symptoms. More cough, more sputum, more shortness of breath. It is very important, if you have COPD, to go immediately to your doctor to ask for help. Because what we know is when you have an exacerbation of your COPD, you have an acute drop in your lung functions. And you never quite get back to where you started, even if you get aggressive treatment. So we want you to drop less so we have an easier time getting you back to closer to where you started. COPD will put people in the hospital with these exacerbations. And so we want to keep people out of the hospital and at work and at home with their families. And most importantly, not having these exacerbations that's going to cause them over time to progress. So we have these 4 stages, and my patients always ask me, what are my numbers? Your numbers are important to me because it helps me know your risk factor for cancer and progression, but you are not your numbers. The most important thing we can do when you have COPD is move. Every study shows that when you maintain your functional status, so doing all the life stuff that we do every day, it's irrelevant what your stage is, as long as you keep moving. So you are not your numbers. So patients can come in and have severe COPD and be okay because they've kept moving. And I have other patients who they find out they have COPD and make it their job to sit on the couch because they're protecting their lungs. And those are the people who go downhill quickly. No matter what lung disease you have, the most important thing is to keep moving. As long as you maintain your functional status, you can live for a long time. So we just talked about these exacerbations. So we talked about how can we help? We can treat you with medications. We can monitor progression and make sure that if you're progressing, we add more medication. We want to keep these exacerbations from happening. We want to keep you healthy and your lungs functional. Patients always ask me, well, if I have COPD, I'm going to go on oxygen, right? The answer is most likely no. Only people with very advanced COPD need oxygen. And I will tell you, it's interesting to me how many people are afraid to get diagnosed because when they feel like once they get diagnosed, they're going to be carrying around oxygen. And it's very frightening. So they just rather not know. I will tell you, there are very few of my patients who are on oxygen because COPD in the beginning is actually not an oxygen problem disease. It's a carbon dioxide problem disease. So it's only very late that people get put on oxygen. And it's typically they also have other comorbid illnesses like advanced coronary artery disease or cancer. So just because you get diagnosed with COPD does not mean you're going to be on oxygen. And the earlier you get treated, the less likely it will be that you get put on oxygen. So if that is your fear, go to your doctor, get diagnosed, and we can prevent that from happening. I hope you have a little bit better understanding of what COPD is, and hopefully a little bit more understanding of asthma as well. And I really appreciate your time this morning. I hope that you have some questions for me later.
Thank you very much, Dr. Fulton. That was quite instructive. We've now heard from the expert physicians, and we all know that when we go and see a physician, we probably don't hear everything. We don't listen to what the doctors are really saying. At least that's been my experience. Maybe it's just the way I'm talking, but I think most of us, especially if you're talking about a cancer or some other chronic disease, we tend not to hear as well. But one person to whom we always tend to listen and we seek out advice, and that's other people like us, namely the patients themselves. We always want to hear what that patient experience is like and kind of guide us as which way we want to go. So we're going to take a quick look and listen to what a few patients have said about their journey as far as with lung cancer.
Okay, so I had asked the question about what can I do because I'm not getting proper care, I'm not getting proper responses from my doctors. After radiation therapy, I haven't heard anything from anyone. And I was wondering what to do. Dr. Jacobs said she wanted to get in contact with me, and she came out of the circle down to the table to catch me before I left. And she wrote down the questions that I need to be asking, who I need to be asking. And believe me, I believe she saved my life. Her and Miss Gabrielle Jones, because Miss Gabrielle been trying to work me through things also. Because to be honest with you, without this group, had I not ran across y'all, I don't know where I would have been. You know, and I still don't know what's going to happen tomorrow. So I said, since I don't know what tomorrow's going to bring, I'm going to get out here now and do my thing while I can. Okay.
All right. And so, Ms. McKee, just wonderful questions. And what we did with Ms. McKee is that we found out who her primary care provider is. She has a book with all of the phone numbers in it, which I think is wonderful. But she also has her lung specialist in here, his information. And she has an appointment that's coming up real soon with that lung specialist. And so what I did for her was I wrote down some questions that I would like for her to ask her lung specialist about next steps. What were the test results? Am I going to have to do radiation again? And then what's the plan? Are we watching and waiting? Am I going to have scans every year? And so we wrote all those questions down. And then as a follow-up, I also wrote my phone number down. So Miss McKee is going to call me. And if I don't hear from her, I'm going to call her. So find out how things went for her. So because we want to make sure that all of her questions are answered. And we want to make sure that she's just getting good care the way it's supposed to be.
And I hope my doctor don't beat me up for telling on it.
No, we really, as doctors, we appreciate it. Sometimes we get real busy in the office and we kind of assume sometimes that patients know. If you don't ask questions, we think that you probably already know. But this way, there will be no doubt. You got your questions written out and you'll be able to ask those questions. And then also, if you can take somebody with you, your son or somebody, another person with you, that always helps as well.
Okay.
All right,
Yeah, because before the radiation therapy, I have my son that lives in Columbus, Georgia, to get on a three-way with me with the doctor so they could explain to him also what the radiation therapy was going to be about. Unfortunately, that was it.
Right.
The last contact after that.
So it'd be a good idea because he can do a three-way again if he can't be there in person with you.
Yeah.
So that's good. So, but we got her on, we believe, on the right track, and we're gonna touch bases. We got a deal. All right.
Deal.
I think it's interesting from that presentation, the importance of number one, speaking up for yourself. We are our own best advocates. And if something doesn't make sense to you, it's okay to ask the question. Some of us tend to be a little bashful when talking to our healthcare providers, and we have no reason to do so. And always a good idea to bring somebody with you. But sometimes you can't always do that. And we depend upon people in the healthcare setting to help us along. And believe it or not, these people are called navigators. And our next speaker, Ms. Carolyn Austin, is one of those such people. Ms. Austin earned her Bachelor of Science in Nursing and Public Management at Florida Atlantic University, followed by a master's degree in nursing science from Florida Atlantic University School of Nursing also. What's interesting about Ms. Austin is that she was influential in developing the Baptist MD Anderson lung cancer screening program. So she was already part of a lung cancer screening program and then brought in the MD Anderson. For those of you who aren't familiar with MD Anderson, it is a large cancer treatment facility down in Houston, national and international recognition. So bringing them up here was a big deal. So she's now the coordinator for the Baptist MD Anderson Cancer Center here in Jacksonville. Ms. Austin will speak to us about lung cancer screening and the role of the nurse navigator.
Oh, yes. Thank you. Down. Okay. So my name is Carolyn Austin. I've worked for Baptist for 13 years, and I was a lung cancer navigator prior to developing the screening program myself. And then now we've had the screening program for 10 years. So I have the unique perspective of seeing lung cancer without screening and how deadly it was, to how wonderful lung screening is and how many patients we are finding in early stage. And we are creating more lung cancer survivors than ever before. So since I have witnessed screening, cancer screening, from before and after, I'm like a huge cancer screening proponent. And we'll go anywhere and talk to anybody about it because I'm just so excited that it helps people live longer. So for cancer screening, I have so many people say, well, I don't have any symptoms. Well, we want to find it before you have symptoms. We want to find cancer when it's easier to treat, like my colleague talked about. And that's when it's found in an early stage, which then increases the survival rate. So what is lung cancer screening? So lung cancer screening is a low-dose CT scan. So it has about 25% of the radiation than a regular CT chest, which is safer for patients. It's like the easiest cancer screening you can get. You basically lay down in the CT scanner. There's no needles. You go in, you go out, and you leave. It takes about a minute, minute and a half. Like, I wish all cancer screenings were that easy. I mean, mammograms and colonoscopies, they're a little rough. But this one, this is the easiest one you can get. Oop. We find them when they're asymptomatic. So lung cancer, typically we do not find it until it jumps on the lymphatic highway and it happens somewhere else, usually the brain. I've had patients that have hip problems, shoulder problems. They come and get a scan and it's a lung cancer metastasis. So we want to find it when it's still in the lung, when it's tiny. So currently, we want to find current smokers and ones who have quit within the last 15 years. I can't tell you how many people I've talked to who tell me, well, I've quit smoking. I'm no longer at risk. No, you are. We follow you for 15 years. So it's important to know that and let people know that let's watch your lungs and make sure nothing's happening in there and keep you safe. So the pack year is greater than or equal to 20, which my colleague already discussed how to calculate a pack year, and the age is 50 to 77. So they recently reduced the age and reduced the pack year a couple years ago because the data that they were collecting from the lung screening registry showed that African Americans actually get lung cancer with less pack years and at an earlier age. Now, insurance covers this at 100%. It's a cancer screening. So according to the Affordable Care Act, they have to cover it at 100%, any cancer screening. So you should not get a bill. So if you get a lung screening and you get a bill, it's usually an issue with diagnosis codes, et cetera. I'm always helping patients to correct that issue so they don't have a bill. So if you get a bill, inquire, something needs to change, and usually it's a diagnosis code on the order. We do have a self-pay rate. We do have patients who only smoke cigars. So lung screening is only for cigarette smokers. We have the most data for cigarette smokers. We're able to measure that by a pack year. So if you only smoke cigars or you only vape or you only smoke marijuana, that we don't have that data for insurance to pay for it. So we do have a self-pay rate, and it's $170 at any Baptist facility. It's $110 for the CT scan and $60 for the radiologist. And we do it at 12 different imaging facilities. As you know, Jacksonville is humongous. And we go into Clay County and St. John's and Nassau. So we are all over. Now we're in St. Augustine. So we try to make it as easy as possible for the patient to get it done. So in the old days, they used to do chest x-rays for lung screenings. And as you can see, we got a lot in the way of the lungs. We have ribs. You can't really find the small, tiny lung cancers. So here's a CT image. So we find nodules as small as 2 millimeters. We really start workup when they're 8 millimeters. I mean, that is tiny. You don't even know what's in there, which is great. That's when we want to find it, when it's real early and it's treatable. So I don't know if you can see this well enough. This is the results from the 10 years with my lung screening program. So on the right, the blue is prior to screening, and that's distant. That's stage 4, which has a very low cure rate. So, and the green, that's how many that we have found in stage 4 with lung screening. So we've found much less stage 4 patients, but what's amazing is we're still finding stage 4, which means that patient is walking around with lung cancer with no symptoms, which is crazy to think. So on the left, the blue, the localized, which is stage 1 and 2, that's how many we found before lung cancer screening. Now the green, I'm finding over 70% of patients in early stage 1 and 2, which is really changing the game with creating lung cancer survivors. So far in the last 10 years, we've done over 30,000 screenings. We're up to almost 500 a month now. 63% of my patients are stage 1. This is huge, 63%. So when I was a lung navigator, the majority of my patients were stage 4. So I would meet them upon diagnosis, meet them with workup to see has it spread anywhere else. I'd walk them to their medical oncologist, their radiation oncologist, and then I walk them to death ultimately because the cure rate for stage 4 lung cancer is very low. Now that is changing because of all the tumor marker, new medications that we have, and someone else will be talking about that later, so I won't go into it, but it's pretty amazing. The lung cancer treatments that have changed in the last 10 years are changing the game for survival rate as well. So here's the staging. So for stage 1A1, the cure rate is up to 92%, which is amazing for lung cancer. In the old days, if somebody had lung cancer, it was certain death. We would not expect them to live, not anymore. So if you look down at the bottom, stage 4 is less than 1% and up to 10% is the survival rate. These stages are ever changing and improving because of the new treatments we have and because of lung cancer screening. Lung cancer screening is changing the game. We find it early, we treat it early, and then we watch them for 5 years and they're cured. It's amazing. So here are some patient misconceptions. I haven't smoked in years. I already talked about how we follow you for 15 years. Very important. I don't have a family history of lung cancer. Well, we hear a lot of talk about colon cancer, breast cancer, and they're hereditary. Lung cancer is not hereditary. It is caused by smoking, radon, and other things that my colleague talked about. I don't have any symptoms. Again, typically, we don't find lung cancer until you have a symptom, and that's stage 3 or 4. We want to find it before you have any symptoms whatsoever. So prevention, I know the colleague talked about it a little bit. Of course, avoid tobacco products, but also low alcohol consumption, staying healthy and active throughout life, and what you eat. Now, this is interesting. There are a lot of other cancers caused by tobacco, which people do not know about. Probably a really big one is bladder cancer. People don't think of bladder cancer as caused by smoking. Well, if you think about you're inhaling something bad in your body, and those things need to be excreted. So those poisonous things that you're inhaling through cigarette smoking and vaping and marijuana has to be excreted through your body. It's excreted through the bladder, and that's why it causes bladder cancer. But it also causes head and neck cancer, a lot of dipping. So if you know, have a family member or friends that dip, they typically get head and neck cancer, one of the worst cancers to get. And esophageal, also rough cancer to get because it does expose other areas. It causes breast cancer because if you think about it, your breasts are exposed to the smoke that you're exhaling. So tobacco is really causes many cancers in many areas. So this is smoking cessation, and I actually have we'll talk about that another time. So on one of the webinars, I learned about lovely Natalie Brown. She had a light cough and unusual fatigue. So why does cancer cause fatigue? It's basically sucking the energy out of you to grow. That's why you get tired when you have cancer. So if you have some unusual fatigue that's not normal, that's something to investigate and find out about. So it took her months. She was young, 33. And the doctor's like, you don't smoke, you don't have any risk factors, you're fine. Well, she was diagnosed with stage 4 lung cancer, and she was a non-smoker. So even though you don't have the risk factors, or you are a non-smoker, I met lots of non-smokers who get lung cancer, you can still have something going on. And so for me, it's important to be your own advocate. We've already heard it several times. And it's important to be an advocate for the sphere of your influence. This includes coworkers, friends, church members. If you have somebody complaining about a symptom that they are constantly having, encourage them to go to their doctor and get a workup. So if there are lung issues, if you're having any kind of lung issues that are not your norm, now some smokers have a constant cough, and that's a normal smoker's cough. That's not what we're talking about. We're talking about something more abnormal, or if you're coughing up blood, or if you have a pain that's a new pain. I have patients that have shoulder pain, and it's radiating to the shoulder. So you have to be your own advocate. If your doctor's like, you don't really meet the qualifications, I really don't see anything wrong, request a CT chest. You can even request for a low dose CT. We can see nodules on a low dose CT, which is the lung cancer screening, and it's less radiation for you. But request it. If you have GI issues that are not normal, request to have a colonoscopy or other workup done. Cologuard is much easier than a colonoscopy. You can ask about that. That's where you just send in a sample. So definitely be your own advocate with your doctors. If they're trying to tell you, no, it's probably nothing, encourage a workup, encourage them. If you don't like what you're getting from that doctor, find another primary care doctor. Have them do the tests you want if you know something is wrong. So there's the acronym BREATHE. For lung cancer. So if you have blood when you cough or spit, that is a sign of lung cancer. If you have recurring respiratory infections, so lung cancer causes irritation in the lung, and it could cause pneumonia and respiratory infections around it. So for my lung screenings, if we find an infection, we then do a repeat CT in a month or 3 to see once that infection is cleared, was there any lung cancer hiding out in there? That's what we want to know. And sometimes we do find it. And during a cough that's new or different, which is what we discussed, and then ache, shoulder, back, or pain. If you have a weird ache that's new, ask for a CT to see if there's anything going on that you are not aware about. Trouble breathing, hoarseness, or wheezing, it'll definitely affect your breathing. And exhaustion, loss of appetite, and that's any new exhaustion. That's something maybe growing that's just taking all of your energy to grow. And so we want to know what's going on. There are resources, so Jax Care Connect can provide access to healthcare. So I know other facilities offer this as well, but Jacksonville with We Care, we offer free lung screenings for them up to a certain amount per year. So you can get a lung screening through We Care. So this is for Duval County residents with a 250% below poverty. So you do have access for it, and that's for the uninsured. And then in Nassau County, I work closely with Barnabas Clinic. They work with We Care to get free lung screenings. And then Clay County has the Department of Health and has Asa Health to help with, individuals who don't have insurance, their poverty level, or they're on Obamacare. Sometimes places don't take Obamacare. This is something that we can help get financial assistance. And that's all. So I thank you guys very much for listening.
Thank you very much. I'm certain that there are many reasons why some of you are here today. And I'm hoping that the main reason you're here is because you want to hear a little bit about what we can do to keep ourselves alive. Now, there's some of you who are here, and there's some really interesting discussions, I'm certain, that are taking place at the tables. All I ask is that you try to keep them down. However, if you don't want to be here, if you don't want to hear what we're talking about, there's a door. And I encourage you to take it and leave. But please do not disrupt the meeting. The information which we're talking about today is being presented for one reason and one reason only, and that is to keep us alive. Too often, we as African Americans are at the bottom of the pail. We don't get the information, we don't get the treatment, we don't get the care, we don't get heard, and we don't get to say what's on our minds. This is not the case here today. So again, thank you for coming, but if you don't want to be a part, Don't interrupt it for the rest of us. I'm sorry to say that. Now, our next speaker is Ms. Yolanda Hildebrand. Ms. Hildebrand earned her Master of Science in Social Work at Spalding University in Louisville, Kentucky, and she's a licensed clinical social worker currently working at the Norton Cancer Institute Behavioral Oncology Center as part of the Norton Health Care in Louisville, Kentucky. Today, Ms. Hildebrand will address us the stigma associated with the diagnosis of lung cancer, as well as managing medical debt and financial advocacy guidelines. Because remember, sometimes the number one cause of debt in the United States, medical bills. So she's going to kind of talk to us a little bit about helping us. Ms. Hildebrand, if you will, come on up. Okay.
Hello, hello, hello. I'm here. I get to talk about the juicy stuff, right? People want to pay attention when you talk about money, right? And the juicy stuff. So the juicy stuff that I'm going to start out with is the stigma of lung cancer. So we all know what stigmas are, right? Let's raise our hands. We know what a stigma is. Have we ever felt like we've been stigmatized, right? So I can just say a few days ago, I'm a healthcare provider myself. I had a doctor's appointment, new doctor, within the organization that I go to. I went in because I had breathing issues. So when I went in, the first thing they did is start drilling me about, do you smoke? You know, do you drink? How often? You know, all these things. So I can relate to what a stigma is, but I also shut that down quickly because I knew that wasn't the issue. As far as lung cancer, anyone can get lung cancer. You don't have to be a smoker to get lung cancer, right? You don't have to be Black to get lung cancer, right? But for some reason, we're stigmatized with it. Now, public messaging is a big deal, as far as us being stigmatized with lung cancer. You know, we have the TV ads, we have social media that shows vaping, we have social media that shows smoking, all these things help stigmatization of lung cancer. One thing that I'll say though, throughout lung cancer, us not getting screened, we're not helping ourselves. It's stigma or not, we're not helping ourselves. We're missing out on health care because of feeling guilt or shame as it relates to a diagnosis of lung cancer. So don't let that guilt keep you from your dignity and respect. So in the job that I do now, I do assessments for patients. And one thing that I ask patients in my assessments often is, do you feel guilt? Do you feel shame? Do you feel hopelessness or helplessness? And most times they say yes. And the guilt is from smoking cigarettes for as long as they did, knowing what the outcome could potentially be. So let's say you find out that you do have lung cancer, or you want to know if you have lung cancer. A lot of the people that were up here speaking discussed ways to go get screening. Screening's the first thing. The second thing, once you get screening, if you do happen to have lung cancer, is to find a medical provider, such as someone like me, a social worker, or a nurse navigator, the Miss Carolyn that just spoke, or even a doctor. So there are resources for you. One other thing that I think is important that I also tell my patients a lot is to support groups, right? People love support groups. I always push support groups, but I push them like on Facebook because everybody's on Facebook, right? So you're not on Facebook? You're not? So you're old school, you're going to go in person, right? So we have those too. But support groups, in my opinion, are the best resource because when you go to support groups, you learn a little bit more about lung cancer. You learn about the resources. You learn about the finance piece of it. You learn about people's experiences and where people went. And that's helpful. Okay. So That's all I'm going to say about stigma. Now I'm going to move on to the financial piece. And I'm going to get from up here. This is weird. So let me come down. I feel like Bob Barker. Okay. Okay. So I'm going to talk about the financial literacy and the impact that it has on cancer care. So, what is financial literacy? For the most part, it's knowing your money as it relates to medical care. Okay. It's being able to understand how much things cost. It's being able to understand um, budgeting and understanding what your insurance does and doesn't cover. And a lot of times we don't know what our insurance covers, right? I don't know everything my insurance covers. And I was saying one thing that I started to do as I get older, or as I'm getting older, is when I sign up for coverage at work now, they give us this booklet. Everybody get that booklet of benefits, right? I keep mine now. I keep it. So then I can look through it and I can, get a good idea of what's covered and what's not covered. So that's a good part of financial literacy. Okay, so the positive part of financial literacy is you get better outcomes, better health outcomes, better mental health outcomes. It reduces your stress because you know what you have, or you know what you need to do, or what you need to get. And it's a better utilization of healthcare because a lot of times we know if we don't feel good, what do? We go to the ER. I've been guilty of that, right? Because you get quicker service. I've been guilty of that. But if we're more financially literate, we know our policies and we know what we need to do. So the negative impact is cancer care is delayed or not even started. Medications aren't affordable, and by the time we get them, it's too late. So, what is financial toxicity? Basically, what that is the strain of money when it comes to healthcare, health insurance, copay, co-insurance. So, I'll go through this. So there are socio-demographic risk for financial toxicity. All right, it's our age. Younger patients don't take it as seriously, so they don't worry about it. Or adult survivors from cancer, they're young. So after they beat cancer the first time, they're like, it's time to party. They go on and they don't get back to making sure they're okay. Income is a big risk. If you have a lower income, it's going to be more difficult to pay for cancer or cancer care. And then also race and ethnicity. So they say our geographic locations, and I know I'm from a part in Louisville that is the west end of Louisville, so predominantly Black. They, for the most part, it's a lower economic status, and so I knew that, and that plays a role in the ability to get cancer care. And then there's the health insurance. A lot of people are either not insured or underinsured, meaning they don't have enough insurance for cancer care. Okay, so additional risk factors is the stages in cancer. We wait too long to get cancer. We're in a more advanced stage that creates more debt. So then there's also risk factors of people that have other comorbidities. I mean, and you may have been diagnosed with cancer, but you also have diabetes, you have high blood pressure. And then there is the risk of the household. So say you're the person that brings all the money in, right? And then you get sick. Where's the money going to come from? How are you all going to meet your bills? What are you going to do? All right. So some of the consequences of financial toxicity not knowing is people may not take their medications because some people won't buy their meds because they're like, well, you know what? I need to eat or I need this medication. I need to feed the family. I need to pay the rent, the mortgage, or I need this medication. So we're going to pick the rent, the mortgage, and the food, right? Take care of our family. So as far as the the debt with lung cancer. All right. There's studies here that show a lot of patients go into bankruptcy from medical debt. All right. And a lot of people do not want to do that. So that's another reason why patients don't get the care that they need. And the United States is real big on it. On here, you see that 62% of bankruptcies are in the United States are from medical debt. And 78% of those people had health insurance. So that's the underinsurance part I was speaking on. So then you have the impact on the caregivers. So you're out, you have cancer, you have a caregiver who is having to take care of you, trying to find funds to pay the bills, trying to take care of the kids, all those things. Those are some of the consequences. So interventions to reduce. One of the interventions would be, like I said, Ms. Carolyn's a nurse navigator, knowing your policies, knowing what's available to you in your community. Asking the hospital, how much is this going to cost? How much is this out of pocket with insurance? The value-based pricing is what the hospital would give you as far as trying to, I don't want to say working a deal out, but working something out so it's more affordable. And then there's the health insurance reform, which of course is going to your state senators and everything to see if they can, make some type of package for it. And then there's psychosocial intervention, which would be me. So, and I say this all the time, if someone's struggling with basic socioeconomic needs, how can they engage in the coping process? How do they start to make sense of their experience? Cancer represents an existential threat, a reminder of our mortality. Financial toxicity may compound that threat. So, and then this is Maslow's hierarchy of needs, which we all learned this in high school and college. And I just wanted you to see the second from the bottom, which is the safety needs. And that is the financial security that we need. So you find out you have cancer, what do you do? There's nurses, there's nurse practitioners, there's medical providers, and there's social workers that can help you. All right. I, again, am a social worker, and one of my main jobs is to find resource to help pay for cancer care, meaning medications, meaning your rent, your utilities, food, transportation, all those things. And social workers are inpatient and outpatient. So I want to make sure I say that, because there's the social workers that are inpatient when you're in the hospital. And then there's me, the outpatient social worker. So I would be the social worker you would see if you were coming to the clinic for care. The inpatient social worker, they may not have as many resources. So you definitely want to be linked to an outpatient social worker. And you can always ask for a social worker anywhere at any time. Now, there also are financial counselors. Financial counselors work in hospitals, and what they do is if you can't afford your chemo, your medications associated with cancer care, they're the ones that may apply for some type of assistance for you. And that assistance is usually through the pharmaceutical company. Sometimes it's through the hospital itself. Now, our hospital has something called Norton Financial Assistance. So what that is if you're unable to afford treatment, there's an application, you fill the application out. If you meet the income guidelines, then what it does is it wipes away your debt to our organization, which to me is a great thing, right? And I think a lot of other hospitals have that. They just don't call it the same thing. So there are different resources. You just have to know about them. And one thing you can always ask. I always ask for assistance if it's available. Even if it's not, I ask for it. And then there's the physician secretary. And a lot of people don't know that the physician secretary, who not only is doing your short-term and long-term disability and your FMLA paperwork, she also has grants and information on nationwide financial resources to help with particular types of cancer. So some of this I've already touched on, but how does your cancer center help? Well, they help you, of acquire insurance or get you to the resources that you can acquire insurance, and they help you as far as being underinsured. So these are the common referrals that I get. Inability to pay rent or mortgage, utilities and other household bills such as telephone, lack of food in the house, or a lot of times when you're a cancer patient, there's a difficulty with nutrition, so we provide boots. So I also help out with that. And then the unemployment for SSDI, which is Social Security Disability Insurance. And a lot of patients don't know, depending on their staging, that they can get what's called a quick approval. And a quick approval is usually 30 days or less. So say you find out you have stage 2 or stage 3 small lung cancer. I would immediately get with a social worker so that way you can go ahead and apply for this. So that kind of helps with some of the financial burden. And then lack of transportation. The American Cancer Society gives free rides if you call. They also give gas cards. And a lot of time I get gas cards from them, which help my patients get to and from their appointments. And then we have a lot of community resources where I live that I can go to help pay different bills, pay mortgage, pay rent, pay car payment. So you just have to look for resources within your community. But again, the social worker is going to be a vital part in finding the resources. And then these are just some resources that I listed, but you guys have a bunch. When I went looking, like this is what I usually give out. But this is you guys here and here, which there's a lot. And like I said, just link with the social worker, and that social worker should be able to assist you with finding resources. So you shouldn't feel that you can't get cancer care because you can't afford it, because there's ways to afford cancer care. So that's it. Thank you. That is super fast.
Thank you very much, Yolanda. That was very good. Yeah, as I said, the one of the biggest things that impacts healthcare is our ability to pay for things. So that's where the importance of being able to contact the social workers or other people to help us. Our next speaker is Dr. Jordan Reynolds. And one of the interesting things about Dr. Reynolds is that one of his big interests in life is making sure we have the next generation of Dr. Reynolds coming along. So he's very much involved in training future doctors. And so I congratulate you for that. Dr. Reynolds graduated from the Northeast Ohio Medical University, then completed a residency in anatomic and clinical pathology at the University of Cincinnati Medical Center and the College of Medicine. He then did a fellowships in surgical and medical pathology and cytopathology at the Mayo Clinic School of Graduate Medical Education. He is currently a professor of laboratory medicine and pathology and the director of the cytology at the Mayo Clinic in Jacksonville, Florida. So I don't know how often you get a chance to talk to a pathologist. Usually it's never a good thing to talk to a pathologist, to be honest about it. But I think now is one of those great times to hear from one. Dr. Reynolds, thank you very much, sir.
Thank you, Dr. Tuxon. Here's the PowerPoint controller. First, I'd like to say thank you to the HEAL Collaborative and for hosting this, and thank you to Bridge the Gap. I do give a lot of talks all over the country, around the world, but this is truly one of my favorite. I love to talk to people in my community. I moved here from Cleveland to Northeast Florida 4 years ago, and I really like to make connections here in the community. So I'm session 5, biomarker testing, personalized medicine, and available treatment options. And I'm a professor of pathology at Mayo Clinic, Florida. The long and short of my talk, because lunch is getting set up and I know everybody's getting hungry, but the long and short of my talk is that traditionally we thought cancer was treated with chemotherapy, surgery, or radiation. But there are other options that individuals may have to get treatment. And whenever I think about these things, I feel like I belong with y'all because I look to God and I look to my faith. So let me just tell you about when I think about biomarker testing, I think about the parable of Jesus healing the blind man. So basically, the disciple said, "Rabbi, who sinned, this man or his parents, that he was born blind?" So first of all, they asked Jesus, who sinned? And Jesus said, it wasn't anybody's fault. And that's how I feel about lung cancer. It's not anybody's fault. These things happen. Okay. And as he's basically sick so that way they can show how great God is in healing him. So Jesus took mud and put it in his eyes and he was healed. So to me, this is like a biblical documentation of biomarker testing. So here's a picture of lung cancer. So I'm a pathologist. I evaluate tissue. And when they give me a piece of tissue, when Dr. Flano or Dr. Fulton gives me some tissue, I may see this. So let me see if my pointer works. Oh, I can't really see. So this represents malignant glands, and this is the lung tissue that the malignant glands are growing into. And I diagnose that as adenocarcinoma of the lung. So my role is to confirm the diagnosis. So they say, how do you know it's cancer? Well, once they give me the tissue, then I can name it, I can grade it, I can stage the tumor. I can say what it's involving, what lymph nodes it's involving, if it's involving the brain, if it's involving the bones, the liver. And then the most important part of my job is to determine if there's enough tissue to find out if there's an actionable biomarker that somebody could, an oncologist can give you. And I know you see Merck up here. They make these biomarkers. They make the tests that decide if you could be on it. So there are two worlds in lung cancer. I would say on the right, 85% are the wild type. They're mainly the smokers, and they need immunotherapy and chemotherapy surgery. But there's a smaller portion on the left, the mutated people, the people who've never smoked. On your bags, you see that there's the African American Lung Cancer Summit. When I go to this thing, I see a lot of people, a lot of Black patients and Black caregivers that have ALK on their back on the shirt, or Ross. So these people they never smoked. They're young professionals. They're going to school. They're working. They're running businesses, and they just got lung cancer. But fortunately, they had a mutation that they were able to get a special drug that would treat it. So lung cancer has really evolved a long way. When I was doing residency back in 2005, we just said it's non-small cell carcinoma or small cell carcinoma, like Dr. Flano talked about earlier. But we started to define it molecularly. So there's a lot, it looks like alphabet soup over there, but there's ALK, HER2, BRAF. There's lots of different markers that we can detect in the tissue to see if you can get a drug that would treat your cancer instead of getting normal chemotherapy. So, the truth is out there. You can go to the National Comprehensive Care Network website, nccn.org. So if you ever get diagnosed with cancer, you can go there and see how to treat your cancer. The doctors use it, the patients have access to it, so everything's there. They interviewed me and they said, is there any hesitancy among the Black community? There's no hesitancy. You're all here to get information, and the information is there. Once you know how to get it and know how to access it, I know you do a great job of finding out what you need. So the red box are things that are detected via next generation sequencing, and the green box are things that are detected using immunohistochemistry directly on the tissue that you give me. So next generation sequencing, they can look at the DNA of the tumor and see if any part of the DNA got put next to some machinery that's gone awry. Those are called tumor oncogenes. So you can get EGFR or KRAS drugs that'll help against that. Other types of mutations are the RNA mutations. They cause fusions. So the people with ALK, ROS, or RET, there was some kind of flip in their DNA that put something next to some machinery that lets the cell live forever. That's an example of fusion mutation. And this can be done by an academic medical center like at Mayo Clinic or University of Florida, et cetera. But more often it's done by a company. So if you're a lung cancer patient, your oncologist may say, well, let's send the tissue to Foundation, Tempus, Caris, Boston Gene, and they'll do a comprehensive assessment of the tissue to see if there's any marker in it. And then the result goes to the oncologist, who can determine the standard of care or enroll you in a clinical trial that they may know about. So, how do we get the tissue? Dr. Flano and Dr. Fulton use this ultrasound guided probe with a needle coming off of it. And you can see that the tumor is going into the tissue, and they give me a sample. And this is called a cytology sample. It's very small, and I can say that that's cancer. So then we can even take that sample and do the next generation sequencing and see what genes are available. And it's becoming more and more common to have a mutation. I would say 25% have a KRAS mutation, 23% have an EGFR mutation, and there are drugs that just go after that mutation. And 36% is unknown, but it is becoming more and more unknown. And these drugs that you get are an alternative to just surgery, chemotherapy, or radiation. And here's an example. There's many studies that show survival curves, but the survival curve is basically showing that if you're on a normal chemotherapy regimen, you have a shorter survival. But if you're on a targeted biomarker agent, you have a longer, more prolonged survival. And as they get second and third generation markers, they're getting better and better at helping with survival. And what's really come up in the last couple of years are something called conjugate drug antibodies. So this is something I learned about in school. I didn't know it was going to be important, but this is what an antibody looks like. And this is something that will mark a cell and it will bring the drug directly to the cell. Those are called antibody drug conjugates. And this has become really popular over the last year and a half. I mean, even last time I spoke at a lung cancer summit, we weren't really talking about this. So this is new. And then, so here's an example of the tissue I showed you earlier. I would do an immunohistochemistry stain that paints the tumor cells brown and says, if you give this drug, it'll land right on that tumor and deliver the drug directly to the tumor. So that's an example of some of these c-Met drugs and HER2 drugs that you hear about in the breast cancer. They can also work in lung cancer as well. And then the other thing that we talk about in biomarker testing is the PD-L1. So if you were to watch the AFC Championship game or the Super Bowl, you're going to see a lot of commercials about pembrolizumab. Well, pembrolizumab is basically, it will, if you have a PD-L1 expression, you will stop your own body's immune cells from killing the tumor. If your tumor is expressing that, it's how it evades the killing. So to me, it's like a matador's cape. If you have a cancer and it has the PD-L1 marker on it, it's like the matador's cape. So if they give a drug to take away that cape, then the tumor cells can kill the cancer itself. And that's the basis of immunotherapy. So going back to that case that I keep showing you, you'll notice that there's tumor cells all around it. However, all these little cells right there are immune cells, and they're just sitting back, waiting, and they're not attacking this tumor at all, probably because the tumor has that matador's cape. So if we were to block that, perhaps those tumor cells would attack and kill the tumor. And then at Mayo Clinic, we have some even more next generation things we're doing. We can take your tumor and we can find out everything that's going on with the machinery of your tumor and make a vaccine just against your tumor. This is called neoantigen vaccine. And there's studies going on right now, but America being a tiered healthcare system, sometimes if you got the cash, you can go to somebody who will make this for you. I think COVID just taught us that it is what it is. Sometimes you got the gourmet COVID test, and sometimes you got to go to the local drugstore and get what's in the bin. That's all we had. So if you have the means, you can get things like this. But pretty soon, everybody's going to be able to get personalized medicine. So in 2024, the Nobel Prize winner was a group that worked on AlphaFold 3, and they used AI. AI is not just for memes and GIFs. They use AI to determine what the protein would look like on your cancer and what the drug should look like to treat the cancer. And now we're getting into an era where you're getting AI-developed drugs. They're able to get these drugs to the market very quickly. They're doing very well. This graph is a little bit hard to read, but these show all the successful phase 2 trials. Most of the time, phase 2 trials don't have that much success. They have limited success, but this is almost like 75, 85% successful with drugs developed by AI. So I really envision a future where if you get a cancer, they can make a drug just for your cancer. And I don't think that that's far away. And the new tests develop rapidly. So from 2004 to 2024, every year they're coming out with new drugs. But I just want this audience to know that if you get lung cancer and you go to your oncologist, you can get the testing and find out if you're eligible for any of these drugs. Just 2 days ago, I got an email saying that some new drug was coming to light, and I had to figure out how to diagnose that and get it to the oncologist's hands. So in conclusion, your tumor may be susceptible to a targeted therapy instead of broad chemotherapy or surgery. And I, as a pathologist, can diagnose and perform the testing at the oncologist's request. And it's up to the oncologist and the patient to evaluate and decide all treatment options, whether that's follow the current standard of care or get yourself on a clinical trial somewhere. So again, I'd like to thank the HEAL Collaborative, and I'll turn it back over to Dr. Tuxson. Thank you very much, everybody.
Thank you very much, Dr. Reynolds. Before I bring up the better half of the Reynolds group, I got to tell you, I don't know if you all could appreciate what he was talking about. It used to be in this day, you'd walk in there with a sledgehammer if you had a disease and they tried to kill it. Now he's going with little tiny pinpricks for specific things. This treatment designed for us, individuals, each one of us, as opposed to just for some mass thing. I think that's interesting. We'll have to hear more about that during the question and answer session. I'd like to bring up Ms. Megan Reynolds. Ms. Reynolds earned her Bachelor of Science degree at Kent State University in Ohio, and then did an internship at the Department of Veterans Affairs in Cleveland, Ohio. She then completed her Master of Science degree in nutrition at Case Western University, also in Cleveland, Ohio. She is currently a dietitian working with Healthy Helpings Nutrition Services in Jacksonville, Florida, where she coordinates nutritional assessment for weight management, control of kidney disease, heart disease, diabetes, and GI disorders. Come on up, Ms. Reynolds. Let's sit back there with him. One of the things I want you to know before she came up here, and I have to tell you, I have to fess up, I didn't know it, but her husband bragging on her made note of saying that in 2021, she was the Ohio Dietitian of the Year. So it's an honor to have royalty here with us. Thank you.
Thank you so much. Okay, well, thank you very much for having me. And I'm here to talk about how nutrition can really help your lung health, which is something that we generally don't really think about helping lung health. What kind of motivates me in this field is my next door neighbor. One day she just came over out of the blue, always friendly, but she had on a sheet of paper and it said ketogenic diet. And she's like, should I be following this diet? And I was like, no, that's typically used for seizure disorders or something neurological. So I was like, no. And she's like, well, I was just diagnosed with lung disease and I hear that I'm feeding this cancer. And I felt a lot of different things at that moment, just sadness and, just not understanding. She's so healthy, things like that. But I also felt really bad because she was thinking she'd have to do something very extreme with her diet in order to change her health. And so since then, I've kind of been trying to find a way to just explain how you don't have to do anything extreme with your diet to improve your health. Half the time, things you're already doing and things that you already know are going to improve your health. And it could just be doing them more consistently. And they're things that you like. So that's what I'm hoping to talk about today. So we're going to talk about how your diet can help with lung disease in general. And then foods overall that really help that are being studied. Specific foods that I don't necessarily have specific recommendations yet, but there's a lot of tests going on regarding these foods. And then foods that seem to not help lung disease that you may want to eat less often, or you may not necessarily want to include these products in your diet. I'm also going to talk about overall the role of a dietitian and how they can help you manage your lung disease and keep you active. And then I'm also a National Board Health and Wellness coach, which is becoming more and more popular. So I also wanted to talk to you about what the difference kind of is and how a health coach can help you as well. So there is a gut-lung axis. There is a axis with everything starting at the gut, basically. So the gut really has a lot to do with our immune system. And so these immune cells travel from the gut along mucosa to the lung. So if there is any dysbiosis or any imbalance in the gut, even like this could be stress, or this could be like some sort of like flu or infection or something else that you're fighting off, that's going to affect your immune system in your lungs. So it could be pretty broad, but you may notice like dysbiosis and like things like bloating, different GI symptoms, things like that. And so treating that can really help your immune function in your lungs. The other thing that we've found out too is that the good bacteria in our gut, which we all have good bacteria, which fights against the bad bacteria. And you may have heard this before if you've ever been on like an antibiotic or something. And then you lose that good bacteria and then you're at risk for an infection or something. So the good bacteria can help fight the bad bacteria. It's a very similar bacteria in the lungs, which we don't think about the lungs having any bacteria, but there's the same type of good bacteria in the lungs. So this good bacteria helps those immune cells fight, and even those fighter cells fight. So you may wonder, well, how do I get this good bacteria? And if it's wiped out of one place, it tends to be wiped out of the other place too. So the way to get it would be things that are said are fiber, like which are typically found in whole grains, fruits, and vegetables, and then fermented foods. Those are two things that have been studied to improve the immune response, specifically in the lung. This is true for acute lung issues such as cancer, but it's also true for COPD and asthma. And actually, that's how this correlation kind of came about, was studying children who, or even infants who, in the first year of life, they had some sort of infection to their gut. And then they were followed 7 years later, or even lasting for 7 years, they tended to have asthma. And there was some sort of correlation between that. And you may know if you have COPD that there are reported changes in the gut as well. So you may notice that you have maybe irritable bowel syndrome or irritable bowel disease, which is like Crohn's disease or something like that, that you maybe never had before until you were battling COPD or something like that. So there's definitely a correlation between that, and we found ways at helping one to help the other. I wanted to share this slide, just a little more information. I don't know if you can see it any better, but some more information about whole grains. Sometimes it's really hard to find whole grains. Since I've moved to Florida, if I go to Publix, I don't see any whole grains. So I don't know how anybody else is finding them either. So I just thought I'd bring up, some things that you may kind of forget or have a health benefit. But one is corn, and that includes popcorn. So I thought, oh, that may be a good one. You may just want to start eating that more consistently. Another one would be oats or oatmeal. Seeking out foods that contain oats, including oatmeal in your breakfast, different things like that. And you may find other things on this list. So quinoa is on here, barley. So you may find some other whole grains, but we're looking for whole grains. Whole wheat bread is one. I find that it's hard to find. If you can find that, great. But trying to get at least half your grains whole grains can help. We're trying to get up to like 25 to 35 grams of fiber a day to really help our guts, which will then help our lungs. This on the other side here, this is fermented cabbage, which more recent studies have shown can really decrease the inflammatory markers. So fermented cabbage could be, this could be kimchi, and this could also be sauerkraut. Now, if you're heating your sauerkraut, that can actually change the fermentation and kind of that good bacteria in it. So trying not to heat that sauerkraut would be helpful. Another one would be yogurt, which you may find that you can also coleslaw or sauerkraut's pretty common at the grocery store. So you may find the other ones. You may find that there's a whole section of yogurt though. There's tons of choices. So these foods, being fermented cabbage or whole grains, are already recommended. So it's nothing extreme that you have to do to get them. These are within our dietary guidelines for Americans, which is put out every 5 years, collaborated by a ton of different healthcare providers, both in endocrinology, heart disease, wellness, dietitians, everything. So you can prevent lung disease or improve your body's response to it just by eating these meal plans that you're already familiar with. The My Plate is the dietary guidelines in an illustrated form. Some people prefer the Harvard Healthy Eating Plate. Same thing. You'll notice that half the plates are fruits and vegetables, and then there's a section recommending whole grains right next to it. So that's true for both of those. The other diet you hear a lot about is the Mediterranean diet. It's also the same thing, very similar to this. You can see that most of the foods are fruits, vegetables, and whole grains in this. So by following any of these, you're able to kind of do those things. Now, simple, but not easy, and you may feel that. These are simple things to do, not easy to do. So think about what it would take in your life I was going to go back, but I'm not sure I can hit up. So think about what it would take in your life to include whole grains at each meal, or what would have to change to do that. Think about what would have to change to include fruits and vegetables at each meal. Think about what would have to change to eat 3 meals a day. And that's also part of the recommendation. So sometimes, even though these are simple things and it's nothing extreme, you have to be consistent with it. And what would you need to do that? So then there's also some foods that have been studied to not help lung disease and not prevent. On this list is processed meats for a few different reasons. So both the nitrates, or the highest amount of nitrates that we consume in our diet, are in processed meats. The other thing are your phosphates, tend to be an additive in processed meats, and those also increase our risk of lung disease. And then the last one is saturated fat. This typically in these same meats also increases our risk of lung disease overall. Then there's vitamin A and beta carotene supplements. So I really don't talk about supplements that much, but this is one that a study was started, a randomized control trial, to thinking that vitamin A and beta carotene supplements would actually prevent lung disease, and the opposite happened. So by not taking, don't seek out taking vitamin A or beta carotene supplements. Beta carotene in your diet, like all the orange vegetables. So I was thinking also like sweet potatoes, carrots, those are good for you. Those can prevent cancer, but taking it in a pill form does not. And then there's also refined foods that contain something called acrylamide. And sometimes you may have heard this, and sometimes this is where starches get a bad rap in terms of maybe like the myths around like a ketogenic diet or something like that for cancer prevention. So when heated at a high temperature, starches then produce this substance, and this can be damaging too for lung disease. This is mainly like 2 of the highest ones are French fries and chips. But thinking like of other foods that you can replace that with in your diet. Other things like toast is another example. And you may find, well, I'm not going to stop eating toast. That's part of my morning routine. But you may be able to toast it less. So if it's burnt, there's a lot of acrylamide in it. If it's lightly toasted, there's not a lot of acrylamide in it. So different things like that you can do. So these are the things that have been studied that show not good, for lung disease. And then there's foods that show promise. So things like tea, any kind of tea. It doesn't have to be green, but green is one of them. Other things like cruciferous vegetables. So trying to include cabbage, broccoli, any leafy greens in your diet can be very beneficial. Soy foods, tofu, tempeh, edamame, all of that can help prevent cancer. And then things I already mentioned, like the carotene-rich foods, are helpful. So sweet potatoes, carrots, curcumin. These are antioxidants, curcumin and quercetin. These are found in different fruits and vegetables as well. And these are really helpful the antioxidants really help with your immune response as well. So these are things, I don't have exact amounts, the studies have been pretty small, but they all show promise in terms of increasing your immune response and preventing lung disease. Okay, so now dietitians, what can they do for you? So you may have liked hearing some of these things, or maybe didn't like hearing some of these things in terms of how much you need whole grains and fruits and vegetables. But a dietitian can help you work these things in your diet in a way that makes sense for you. They can also help you if you're going through something like cancer treatment or treating COPD. These are very debilitating diseases. Getting enough calories is very important in helping you maintain your strength and physical abilities, and a dietitian can help you do that. And then staying healthy for life after cancer as well. So for prevention of any type of reoccurrence and overall just maintaining your health. So this is how a dietitian can help. Dietitian, other things that we'll do would be like to start with like an initial assessment where they kind of assess your diet, help you see maybe what nutrients you're not getting enough of, what nutrients you're getting too much of, and make a plan with you that makes sense. They can also diagnose you with malnutrition, which isn't necessarily related to weight and is not as obvious to see. So, so those are ways that they can help you in getting the resources you need to be healthy. These are some websites I really like for nutrition information for cancer. There's the cancerdietitian.com. Another nice one is survivorstable.com. And then you can also find a dietitian at eatright.org. There's a little button, it's orange on the right side, that says find a dietitian. And then we actually need your help too, expanding nutrition coverage with Medicare so that it covers all diseases. So right now, Medicare is only covering kidney disease and diabetes. And, if you have like an artificial means of nutrition, like a feeding tube or something like that, but we really need coverage for all diseases. And there's policies that you can ask your congressman to vote to cover this. We're asking Congress to approve them now. So the Academy of Nutrition and Dietetics is working for us to have more accessible or more access to a dietitian. There's also a bill that is stopping telehealth in January, at the end of January. So it was extended through January, but now it's supposed to stop. So also, if you know your congressman and you have a relationship with them, please, on our behalf, please encourage them to not stop telehealth, as that would decrease access to dietitians as well. Now, really quick, a National Board Certified Health and Wellness Coach. This is a newer certification. However, this certification they're trying to get it covered under Medicare as well. The reason we want things covered under Medicare is because all insurance tends to cover it then. So this would also increase your support of your health and increase your access to care. The difference between a health and wellness coach and a dietitian is that a health and wellness coach does not prescribe anything, any supplements, anything like that. And they also don't diagnose anything like malnutrition or anything. So they are a generalist when it comes, like they are there to walk side by side, even think of them as like your co-pilot with going through this, and to guide you in making your wellness vision and maybe setting up some goals, like your 3-month goals, even a weekly goal. What do you want to do this week? These goals, we try to follow the format of SMART goals, where they're specific, they're measurable, they're action oriented and timely. So they make sense and they're individualized for you. Things that a health coach can work with you on, of course, like if you've already seen a dietitian or if this talk was enough for you and you know what you need to change in your diet, they can help you make those goals and make those changes. They can also help you with quitting smoking. They can also help you manage stress and even getting enough sleep and your physical activity level. So really just overall, between a dietitian and a health coach, I like to, and we all like to provide just a holistic way for you to stay healthy and improve or maintain your lung health. That's all I have today. Does anybody have any questions? Mhm.
Thank you. Thank you very much, Ms. Reynolds. We appreciate that. quite a bit. I know some of you are kind of disgruntled by some of her suggestions, especially the toast. All right. We're good. I'd like to bring at this point, first of all, I know we're having a little bit of difficulty with the slides, and I appreciate everybody being very gracious and knowing that the guys have been working through that. But I want to make sure we give, if you would, please, though, give a hand to Justin, Steve, and to Trevon in the back, who've been really doing a great job of getting this stuff up, the sounds and all that. And we really appreciate you doing that. With that, you've heard her introduction before. Bring up Ms. Carolyn Austin, who's going to give us a short presentation on smoking cessation, providing support and resources to assist patients and families. Yes, Steve, I did say you too, sir.
Thanks. So this time we're going to touch on smoking cessation, and we have a lot of options for that. So I think with smoking, there definitely is a stigma with it. I feel like back in the day, there was a generation. I mean, they gave cigarettes to military personnel. They would hand them out. There were advertisements back in the day for pregnant women to smoke so they wouldn't gain so much weight and they would have a low birth weight baby. I mean, it's terrible that the tobacco companies promoted cigarette smoking so much, and the goal was to get you addicted to that nicotine. And that's what we need to recognize, is that it's an addiction. It's not a choice. I have so many people who say, well, why can't she just quit? It's a choice. She can just stop smoking. It's not a choice. It's an addiction. And that's something where we are trying with American Lung Association and Cancer Society to change that thought process, to really look at it in a different way, and that it's not a choice. So we want to support them. And when I deal with lung cancer patients, they feel like they did it to themselves. They feel guilty that they're diagnosed with lung cancer. They feel guilty that they made that choice and caused it to themselves, but they did not. No one deserves cancer. No one deserves lung cancer. It is an addiction, and we shouldn't blame ourselves for that. We've already gone through this slide about how it causes several other cancers. And then here are the options. So when the lawsuits with the tobacco companies, part of the settlement was that they had to pay for smoking cessation services. So Tobacco Free Florida is a website. You can go online and sign up with them. They will provide email, phone, and text support. So if you're trying to quit and you have a stressful day and you really want a cigarette, you have options to reach out to them and have a supportive person help talk you through not taking that cigarette. When you do sign up with them, they give you 2 weeks free nicotine replacement therapy. Then they will refer you to AHEC, which is a local smoking cessation chapter that I work very closely. They one in Nassau, Duval County, in Orange Park area, Clay County. I work with all of them very closely. I learn new things all the time from them about vaping that is flavored with cupcake and bubble gum, just to get those younger kids addicted to the nicotine. So they have a 6-week course. They have a virtual and an in-person, which is great. If it's hard to get to the location of the class, you can do virtual. Once you complete this 6-week course, you can get 6 weeks free of nicotine replacement therapy. And then if you call back Tobacco Free Florida, they'll give you 2 more weeks free. So you can get up to 10 weeks free of nicotine replacement therapy. So I have heard patients say it's hard because these NRT is very expensive, but there we have an option to get 10 weeks free. And one part of the AHEC course is that they have the attending individuals put the money into a jar that they do not spend on that pack of cigarettes, and then add it up after a month or at the end of the 6-week course. And you will see, they'll complain the NRT is so expensive, but you'll see how much money you're saving on cigarettes. So I think that's a very great way to show how expensive this habit is. Let's see if I have one more thing. I think that's about it. So some things of what to comment on some of the other presentations. The tumor markers and the targeted therapies that my colleague talked about are really amazing. And I met a patient who was in the clinical trial for one of them. She was out of the trial. She was stage 4. She was like 8 years survival. And they didn't know how long she was going to live because these treatments are doing so well. We have patients who are on immunotherapy. They have no evidence of disease. Well, they're doing studies now to see, well, what do we do next? So there's so many new treatments for lung cancer that these stage 4 patients are living longer and longer, and it's pretty amazing for them. Regarding the financial aspect, at Baptist MD Anderson, when you come in as a new patient, you also are required to have a meeting with our patient financial counselor to help assess your insurance, how much are things going to cost, do we need charity care? We do have a certain amount of charity care for patients to make sure that patients, once they're in treatment, they're not stressed out about the expenses of the treatment. And I think that's about it. So thank you so much.
We're going to take a few questions. So if you have a question, please raise your hand and I will come over to you. But I'm going to keep our speakers over there at that table because they're old and they can't move around too well. I'll trade you. Take this from. Would you take this one? Take that over there to the table. And they can pass that around. Hold on, I'll be right with you on that question. Okay, I'll start here and then come back there. Yes, ma'am. Please, could you stand up for us, please? Yeah. Oh, that fancy red one. You must be from Louisville Cardinal, right?
No. This is for Carolyn. On her chart, it said that for lung cancer, the cancer survival restricted to people 60 to 77. Since most of us are seeing over 77, what is available to us?
So the question was, if you didn't hear it, if screening gets a cutoff point, what do you do if you're over the age for accepted screening?
So at Baptist Health, we follow Medicare guidelines, which is age 50 to 77. The USPSTF recommends age 50 to 80. Unfortunately, Medicare Advantage plans, I've had so many patients, I've fought for them to get it paid. They will not pay for it. So that's why we follow Medicare guidelines. So I have lots of patients who passed the age of 77. I just had an 89-year-old screen. And you can pay the self-pay rate. So it's $110 for the CT scan, and then it's $60 for the radiologist to read it. So it's a total of $170. And then you can get that every year. Because with lung cancer screening, most of our lung cancers aren't found until like 3rd, 4th year of screening. So I have a lot of patients who will say, I'll do it next year. No, we need to do it every year. So we make sure if it's showing up, we're gonna find it that next year.
And I want to point out too that we should always, if you're in that outside the accepted guideline, one of the things that Dr. Flano was able to do was very much instrumental in dropping the age of, I see you came back. The age was 50, but if you notice the age has dropped down 45, I believe, for the African Americans because of what you were finding. Is that correct? Could you pass the microphone to him, please? Thank you.
Yeah, it actually, it's 55. Originally, it was 55. We dropped down to 50. What we found, and we reported it, is over like a 4-year period, I diagnosed about 180 new lung cancers a year. Most of them are African Americans, about 97%. But I was finding a lot of patients were underneath the age. About 11% were underneath the age for screening that actually had cancer diagnosis. Another 6% were above the age. So if you think about that, these are people we actually diagnosed with lung cancer that they didn't even have a chance to get screened to catch it early. So we published it back in 2019. There were a couple of other studies that came back to look at tobacco use history, that African Americans smoke, just like the data we showed you earlier, that they smoke less, but the cancer rates are still high. And in a couple of years, those 3 studies were noted. And part of the push to get the age to include more African Americans that were at risk, had the highest risk for lung cancer. So that's how that developed. So it's another important reason why we should be involved in some of the studies, because if we're not part of the studies, then the data, the guidelines, the recommendations don't reflect what's helpful for our population.
Thank you very much. We have a question.
Okay, I would like to know, does medical gummies and medical marijuana have the same effect?
So she's really asking the question. She wants her cannabis, but you told her she can't smoke it. But can she get her gummy? Can she get her fix that way? Am I right? So the question is it the cannabis, or is it the smoking that's the problem? I got you.
So what I talked about was tobacco. No, what I talked about was smoking. If you have a prescription for your gummies, and speak with your doctor about that. But keep in mind that the addictive part, or the thing that causes the high, is THC. It's not the exact, it's THC is a chemical that's inside of the marijuana. It's not what's causing cancer. It's very similar to cigarettes. It's all the other burning products that get into your lungs and go from there. So I'm not going to tell you it's good or not. I would talk with your primary care about your gummies. Don't put that one on me.
All right, gummies and brownies are okay.
Yeah.
We had Dr. Jordan. We had a question came in on the Facebook, which was, if you have COPD or if you have other pulmonary problems, when is a good time to be referred to a pulmonary rehab specialist, or do you get referred to somebody like that?
That's a fabulous question. So pulmonary rehab is really important for people with advanced disease. And what it does is it helps you learn what you can do and what symptoms show you, okay, we need to slow down, but we can keep going through this, how we work through this, or no, this is your body telling you it's time to stop. We need to sit down, recover. Pulmonary rehab is limited to patients typically on oxygen. And I already told you that's late. So the other population that can benefit from pulmonary rehab are patients in stage 3 with their PFTs. So again, very important to get your PFTs so we can help you access pulmonary rehab. And it's also advised in other disease states such as interstitial lung disease, also called pulmonary fibrosis. So it's helpful in every lung disease that for patients, but to get access, you need to get the testing. So there are several pulmonary rehab centers here in Jacksonville, and they show huge benefits in terms of functional status. But again, you have to meet the criteria. And so unless you're seeing a pulmonologist or somebody who can do the pulmonary function test and get you through the system, you're not going to get access. So make sure you get to your doctors.
All right. Dr. Reynolds, we had a question that really centered on environmental pollutants or factors in the environment that may give rise to the development of lung cancer. Did you want to tackle that, or you want to leave it to, I was going to ask the pathologist, but we can ask one of the clinicians. I mean, we always go to the pathologist for the final answer anyway.
That's a very good question.
Especially cleaning products.
Yes, that's a very good question. We're so used to diagnosing and naming things, and we haven't done enough research on what exactly is causing it. But I thought I could ask Dr. Flannel if he had any insight on this.
So there is a lot of, and that's when I was talking about environmental factors, a lot of environmental factors. There's safety recommendations, guidelines for industrial type of solutions, cleaning solutions. They recommend wearing a mask, wearing eye protection. There's a reason for a lot of those, because they do cause some harm. All of these are chemicals which can influence cell growth, differences. So just following those general recommendations is extremely helpful. Environmental and toxicities, yes, we can map this out. There's some areas like even in Kentucky, you know, the is it Rubber Town, right, where a lot of the factors are. I drove through there one day, and you could actually just smell the chemicals that are out there, and the cancer rates are higher in that area. But you know, they know that the pollutions were there, the factories are there, the toxins were there. Those houses are cheaper, and people who need to live at a lower rent rate live in these areas and is almost trapped to be exposed to a lot of these chemicals. This is where it becomes important. And I was telling him last night, you know, I'm going to say something that's going to get me deported. This is where it becomes important to vote and what you're voting for, right? Because lately there's been a lot of push to decrease the Environmental Protection Agency's uh, ability to regulate a lot of these factories and these chemicals and whatever else. And so we need to understand how a lot of the things that are going on are impacting us. But yes, environmental toxins, pollutants, they do influence your likelihood of developing not just lung cancer, but other types of
I
cancer.
had another question, very similar vein, Megan. You've talked about the foods that we should be eating, and also there was a question about that burnt toast thing. You caused a lot of problems about burnt toast. Now, but seriously, it's great. All the stuff we're supposed to eat, but tell me about food deserts. That was the thrust of the question, where we can get this stuff.
Yes. So in terms of food deserts, that's a major problem. So where you can get these foods is just getting to a store that has them. Food deserts, like if it is a gas station or something like that, that's the closest. Looking for like things like dried fruits. If there's anything that they have like refrigerated, sometimes it'll be like cut up vegetables, things like that. Um, Myself, there's not a lot of whole grains in at like corner stores and things like that in this neighborhood either. So really looking for bigger even if it is a gas station or a corner store, talking with the owner and seeing if they can incorporate any of those things. If like honestly, I don't know if anybody else shops at Dollar General, but there is quite a few different, like at least a few different choices in terms of frozen vegetables typically, and then relying on either dried fruit if it's available or something frozen.
All right, we have one more question, and I apologize. Boy, I'm glad all the people raising your hands, but we got to move on to the next session. But we will be around at the conclusion of things, so please don't get mad at me, please. I apologize, but blame Dr. Fladeau because he talks so long. He's going to be deported anyway, so I don't care. But come on, there you go.
The biomarker testing was very interesting to me, and I just wanted to know that if different markers was looked for in African Americans or different ages than was looked for in other races.
And let me add on to that. We always hear this thing about blacks have such poor survival. Is it that we have genes that are different from white folks, or we really all have we all have the same kind of genes? It's just that the other things that are impacting the mortality rate.
I thought Dr. Flannel said it best. I mean, it's multifactorial on why blacks are diagnosed at a later stage or why they have poor survival. But for the biomarker testing, I did not. I really think it's a support and getting organized thing. So when we go to these lung cancer summits, like what is on the bag that is giving you, there are lots of young black patients that have these mutations. I didn't even know black people got this. I mean, they usually talk about Caucasians or the Asians are the ones that get this. And you see groups of people like that. I think they need to get on Facebook or on social media and form these groups and get support and let them know we're here and we're willing to participate in these studies.
Well, thank you very much. Again, I really apologize. We're not going to get to some great questions you all are asking, but we will be around here after the program ends. So do come up and talk to our speakers. I want to move to the next part because this is kind of an important thing. When Ms. Hildebrand was talking to us about the financial side of things, the question comes down, how do we pay for these medications? Because we all know medications aren't cheap. So we're going to have three guests. First, we're going to have as our moderator, Mr. Howard Mosby. Mr. Mosby, well, I'll tell you what, let me introduce the other people first. And first, we're going to have Mr. Thomas. You don't mind if I introduce everybody? Mr. Thomas Johnson, bring him up. Mr. Johnson is past president and chief executive officer of Medicaid Health Plans of America, where he spearheaded in advocacy efforts involving the Affordable Care Act, also known as Obamacare, and other policy issues affecting the Medicaid managed care industry. He is here today as the executive director of Alliance to Save the 340B program, also known as the ASAP 340B, which was formed to bring greater accountability and transparency to the 340B program so that it can function as intended, enabling true safety net providers to help low-income and other vulnerable patients access more affordable medicines. We also have Mr. Josh Spagnola, who you saw earlier. Josh obtained his bachelor's degree in economics from Florida State University. Do they play football up there? Not anymore. Not anymore, okay. He has an extensive experience in legislative affairs, including policy, chief health and human services in the executive office of the governor of Florida, and Deputy Chief of Staff of the Florida Agency for Healthcare Administration. He's also Director of Legislative Affairs for many private companies, and he's currently the Director of Regulatory Strategy and Corporate and State Government Affairs for AstraZeneca. Finally, Mr. Mosby, who you heard earlier. Mr. Mosby represented the 83rd District in Georgia House of Representatives for 8 terms. He served on the Ways and Means, Health and Human Services, as well as Government Affairs and State Planning and Community Affairs Committees. He is a certified public accounting and is the vice president of faculty contracts administration in the Division of Medical Affairs at Grady Hospital in Atlanta. As you heard earlier, he's also the co-founder and corporate treasurer for the HEAL Collaborative, and he'll be moderating this last session. Thank you.
All right, good afternoon. I know I'm standing between you and lunch, so this is going to be fairly brief. In this final session, we're going to be switching gears to this 340B medicine topic. How many of you have ever received free or reduced medications from your healthcare provider? All right, we don't have enough hands going up here, so this is why we're here today. We're going to keep this conversation informal and interactive, so don't worry about the jargon because we're going to explain anything that we say up here that doesn't make sense. But if you're not familiar with 340B, don't worry. This thing was started back in 1992. It was basically a federal program that was designed to have pharmaceutical companies provide drugs at a deeply discounted price that they sell to hospitals and covered entities, free, federally qualified health centers, these clinics. And so basically it's about the hookup. So if I can buy drugs at $50 and sell them at $150, I'm supposed to use that profit to help communities like this. Now the question is that happening? So Mr. Thomas Johnson has a presentation of it right quick. He's going to show you why no makes sense. Amen? Y'all ready? Let's get to work.
Thank you, Howard. Thanks, everyone. I know I am, as Howard said, we're the last group before lunch. So we're not only going to try and make this quick, but we want to try and make it interesting. And maybe you'll learn a little bit something about a program a lot of people don't know about. But as Howard stated, it's the second largest drug discount program in the country, which now comprises $84.1 billion in drug purchases. So these are the members of our coalition. We have 41 members. We've grown from 17 members over the last 2.5 years. They include groups like the National Association of Community Health Centers, blackdoctor.org, the National Hispanic Nurses Association, the Center for Black Equity, Black Gifted and Whole, the National Hispanic Council on Aging, Pharma, and Patients Rising. They are groups representing providers, consumers, those who look after the interest of people of color, clinics, and also the pharmaceutical industry. which has a lot of concerns about the recent nature and direction of this program, which is supposed to serve the underserved and those providers that are serving the underserved. Congress created this program, as Howard said, over 30 years ago to help low-income and other vulnerable patients access more affordable medicines. To the tune of, in the most recent year, covered entities that qualify for this program can acquire those drugs at about a 59% discount of the price of the drug. Community health centers and other safety net providers rely on this program to serve their communities, but some entities participating in this program, and I will specifically speak to hospitals, have taken advantage of the lack of clarity at the expense of the patients it's meant to serve. So this is what's supposed to happen in this program. The program is set up so that a pharmaceutical company that wants to participate in a program like Medicaid, they're required to enter into agreements with certain types of entities that we call covered entities, hospitals, community health centers, HIV/AIDS clinics, and many others, to provide a drug at a discounted price. The average currently is a 59% discount. The entity is able to keep the 41% of the price by reselling it or billing your insurance company, or whether you're under Medicaid or Medicare, billing at the price it acquired the drug for. So they're able to keep that amount of money. And that allows them to stretch their resources to try and serve the patients that they serve. Unfortunately, increasingly, this is what's happening. Instead of billing that insurance company or Medicaid or Medicare at that acquisition rate, because the law is silent on what they can bill, there are hospital systems that are billing at 500 to 1,000 of the price of the cost of the drug that they acquired it for. 500 to 1,000% for a program that's supposed to be for the underserved. And are patients getting any of that discount? What do you think the answer is? No, they aren't. So this is what's happening with the program, and these are some of the consequences of not trying to reform this program so that practice and other practices can stop. So $66.3 billion was a total discounted purchases within the program in 2023. That makes it the second largest discount prescription drug program in the country. Figures came out yesterday from HRSA pushing that 66.3 number up to 84.1 billion. So that means both in 2023 and in 2024, the program increased each year by 23 to 24%. The vast majority of those purchases in this program, 87%, are made by hospitals that qualify for the program. All of the other categories, community health centers and HIV/AIDS clinics and others, represent 13% of those purchases. And you'll see why that is important as we go through some of the issues surrounding this program. This program has expanded as have the number of covered entities and middlemen. When I say middlemen, I mean PBM specifically, which are drawing down $2.5 billion from this program as they help in setting that increased price 500 to 1,000% for a drug that was acquired as a discount. So they're drawing some of that money for themselves. There are few transparency and accountability measures. There are hospital entities that are using money for pretty much whatever they want. And when I say whatever they want, I mean they're using them for capital improvement projects. They're using them for the naming rights of arenas. One in particular used their dollars to pay for the salary of their football coach. Now, all of these dollars are not going back into patient care and certainly not representing the discount that's supposed to be received. These benefits flowing away from low-income patient communities help hospital consolidation as hospitals prioritize patients with higher paying private insurance. And they're starting to build facilities in affluent areas that have more patients that have private insurance and applying that discount to those patients, even though this is supposed to be a program for the underserved. And again, PBMs and other middlemen are siphoning billions from this program. So in April of this year, Senator Bill Cassidy from Louisiana, who chairs the Senate Health Committee, released a report on the 340B program. And these were some of his findings with regards to certain hospital systems. The Cleveland Clinic's total 340B benefit from April 20th through June 23rd was $933 million, none of which was passed directly to patients. Instead, it was absorbed into operating budgets and capital projects. Bon Secours Mercy Health in Richmond, Virginia, their total was between September 2018 and September 23rd was $276.5 million. Despite being located in one of Richmond's poorest communities, Bon Secours used its 340B profits to fund expansion into wealthier areas. Patients at Richmond Community Hospital saw no direct benefit from the savings, and in fact, Richmond Community Hospital reduced some of the services that they provided to uninserved patients at that facility. Sun River Health, according to its financial statements, Sun River's gross 340B revenue generated over a certain time period was $105.1 billion, primarily from HIV, AIDS, diabetes, and hepatitis C medications. 3 of its 30 clinics produced over 50% of the program's revenue. Now, I talked about the fact that transparency is a big issue with regards to this program. And here's the rub with that issue. Community health centers and other types of entities are designated as HRSA grantees. They receive money from HRSA. They qualify for their status as grantees. They're required to report how grant funds and 340B savings are used. They reinvest that savings back into patient care, and they have a sliding fee schedule for patient drug copays when patients are billed directly. They're part of the 13% that are outside of the hospital systems. The 340B hospitals, primarily DISH hospitals, they qualify for 340B by serving a disproportionate share of low-income patients, DISH hospitals. But they have no federal requirement to report on how 340B savings are used. The public does not have access to that information. The only reason why we were able to share that information with you about those 3 systems is that Senator Cassidy asked for it as part of his investigation. There's no obligation to reinvest savings into patient care. That's why if you looked at the Super Bowl this year, there was an ad by a 340B hospital that was valued at $8 million. And in terms of requirements to provide charity care, 2/3 of DISH hospitals were below the national average of 2.5% of operating costs. And that's outlined in this slide. 340B hospitals providing 2.15% of operating costs in terms of charity care, nonprofit hospitals at 2.3%, and for-profit hospitals at 3.8%. In the area of cancer specifically, there's been a lot of work done by the American Cancer Society, the Community Oncology Alliance, and other groups with regards to what's happening in this space in cancer care. And you can see how now this has become a profit margin area for 340B hospitals. So what they're doing is that they are using high-priced drugs on purpose and charging amounts for that drug way in excess of what they acquired the drug price for. Revenues generated by 340B hospitals for cancer therapies, according to the American Cancer Society, was over 10 times higher than at non-340B hospitals. North Carolina, the state of North Carolina produced a study showing that 340B hospitals charge state employees more than 5 times the cost for cancer drugs, an 84.8% markup. And in one specific case in Virginia, there was a patient, the drug, her cancer drug cost $5,000. I'm going to get to the worst part, actually, at the end. The hospital billed Medicaid $22,700 for that drug. Okay? Under the 340B program, the acquisition cost of the drug for the hospital was $2,700. So they took a $2,700 drug and they billed Medicaid $22,700 for it. Medicaid paid $10,000 for that drug. So the profit is there. It's way above what should happen, but the profit is there. So what did the hospital do? They turned around and they sent a bill to that patient for $2,700. So there is activity in Washington. Both the House and the Senate are involved in trying to come up with some measures aimed at some of these practices that hospital systems have been engaged in. There is also a pilot program that is starting on January 1st, where actually the pilot program, which is voluntary, what it actually does is instead of reducing the cost of the drug up front, it actually, for 10 specific drugs, it actually will force covered entities to provide that, to purchase that drug at the actual cost, not the discounted cost. And then they would get a rebate by the manufacturer. There are other groups that are involved in trying to get reform to the system, including blackdoctor.org, the NAACP, the National Council for Negro Women, and other groups, which have the same concerns that we have and want to see reform take place with regards to this program. I am happy to say that the HEAL Collaborative is a member of our coalition and is very active to try and get reforms to this program. So our solutions are ensure that savings are used to help patients and true safety net providers receive the benefit of that discount, prevent abuse by middlemen, and through transparency and making these things reportable, verify that this program is actually working. Thank you.
So you heard a lot here. And before I bring up Josh with AstraZeneca, a couple of things. More money, more, more money. All right, so Mr. Johnson said a couple of terms that I want to clear up. HRSA is Health Resources Services Administration. It is a federal organization that's required to audit entities, whether or not how they use this money. $0 are coming from your tax dollar. All of this money is coming off the bottom line of pharmaceutical companies. So this is not tax money that these entities are using. They're actually abusing these pharmaceutical companies, number one. Number two, he mentioned PBMs, which is pharmacy benefit managers. Now, so let me ask any of you, how many of you ever bought a brand new car? Everybody bought a brand, well, a lot of folks bought. How many, so who ready? Let me get somebody close. Who'd you buy it from? He bought a Lincoln. Did you buy a car from Ford or did you buy it from a dealership? He bought it from a dealership. Now, you cannot buy a car from Ford Motor Company. You can't buy one from GM. You can't buy one from Lexus. You can't buy one from BMW, whoever. You know why? Because you got to buy it through a dealer. Now, the price of that car is being affected by a whole bunch of factors before you even see it. Same thing with pharmaceutical companies. You cannot buy drugs from AstraZeneca if your life depends on it. You can't buy drugs from Pfizer, Merck, or whoever. You buy them from the pharmacy. How many people got their hands in between the time that drug is bought and time to the time it gets in your hand? Most of that is governed by pharmacy benefit managers. They negotiate prices, and then they cut a little piece off the top, more money, and then they charge you for that. With that, ladies and gentlemen, I'm going to bring up Josh Pagnola. He's going to speak briefly from the industry standpoint for what's happening with 340B. Thank you.
All right. Thank you, Thomas. Thank you, Howard. I'm going to pause for a quick second on 340B and go to biomarker testing with Dr. Reynolds. This is quick, I promise. It's an innovation. It's a game changer. It means nothing if you can't access it. So in 2024, there was a bill in Florida to grant access to biomarker testing through Medicaid. That was important. Your state representative, Kimberly Daniels, and your state senator, Tracy Davis, voted for that. What's missing is coverage for biomarker testing for everyone in Florida. That's what we have to do next. I can tell you, your state representative, your state senator, if that bill was there to expand coverage for everyone and not segment it out, they'll vote for it. So you have champions here that represent this community. So it's important. There's a lot of work to be done, and the innovation doesn't mean anything if people can't get it. So unpause, 340B. So it was a program, as Howard just said, designed in 1992 to correct a mistake that Congress made that hurt public hospitals and clinics. We support that program as it was designed so that institutions could buy the drugs cheaper, get paid the full price, and use that difference to help fund programs for underserved areas, indigent care. It's grown since then. AstraZeneca and other drug manufacturers support that program as it was designed, and we believe that the benefits of that program should go to what the original intent was. So I've heard examples of hospitals that have mobile lung cancer screening units, a lot of stuff that we talked about need here today, and they go to communities where there is unmet need, and that program is funded with 340B dollars. That is how the program is supposed to work. What we have a concern with is the size of the program. Like Thomas said, now the second largest federal drug program. You probably may never have heard before today. It's larger than Medicaid drug benefit, and there's no accountability. There's a lot of money that's going to the system. Thomas talked about the PBMs, the middleman. There are over 75% of the pharmacies that participate in the 340B program run through the large chain pharmacies and are located in areas outside of the communities that were designed to get the benefit of the program. So we have to rein in the program. We have to ensure that there's transparency and you can understand where the money's going. You can right size the program. And then if you do that, you will have a program that functions the way it was supposed to, and the benefit will come to the areas where it was meant to. The whole reason it was designed in 1992. I will say with the growth, now $84 billion per year, there's a lot of unintended consequences to that. An example of that is it hurts the Medicaid program. It takes dollars away from the Medicaid program as you grow the program. If somebody is tagged a 340B patient and they're also a Medicaid recipient, the rebates that go to the Medicaid program cannot be given to the Medicaid program. You can only have one discount. So in that case, if it's a 340B patient, that discount does not go to the Medicaid program, it'll go to the 340B institution. So as you continue to grow it, and I would say expand the program way beyond what it was designed to do, you're taking money out of the Medicaid program. Same thing with small businesses. It's hard for small businesses to provide insurance coverage. Over the last 10 years, about 8% of the increase in premiums for employers and employees has been a result of the growth of the 340B program. So I'll summarize this because I see food back there and it's been a long, very great day. I'll summarize this by saying there are efforts in states to expand the program even further beyond the $88 billion, require no transparency, have no provisions that money comes to the areas where there's high uninsured populations and areas of need where it was designed. My suggestion is that those bills have to stop in the states and we look to Congress to do the things that Thomas laid out. Make sure that money's going to the people it's designed to go to, make sure there's transparency and that you're closing loopholes. So I'll go ahead and stop right there. I appreciate your time. I appreciate, like I said earlier on lung health, it starts with you all. We can't find out what the gaps are and we can't get people in Tallahassee and Washington, D.C. to change without you. So the fact that you are here and you were highly involved means a lot to everybody here and it helps us do the work in the capitals. And like I said, you have a great state representative and a great state senator here. If you ever see them, tell them to keep up the good work and to make sure that they're looking out for the healthcare and everything else of this community. So I appreciate it.
Thank you. These guys did a good job. We'll take 3 questions from the audience. He said no question. They're ready to eat. Dr. Jackson. Yeah. Who had the hand?
Now, I'm going to do this real quick. Now, I stopped smoking about 2 years, long time ago, and started back. But I can't tell you the reason. But I don't smoke as much as I used to. I might buy the cigarettes, but they beg you for more than you buy. So, I'm telling the truth. But me, as far as that medicine, it don't do nothing but make me go to sleep. And make me feel better from this pain that I'm in with arthritis. That's all.
Thank you for that point. Is there a question related to the 340B? We'll get an answer to that a little bit later. I'm sorry, I see a hand. You're over there. Well, I know it broke up a little bit, but the question was, when going to see their doctor, should they ask about, is this medication covered under 340B?
They should definitely ask what I would call any institution that you go to. So if you go to a hospital, if you go to a clinic, you should definitely ask. One thing that I think is important in this campaign to help with reform is to make sure that providers understand that the patient community is becoming more and more aware of this program. And, it's amazing to me, I've been doing this for 2.5 years. And the first couple groups I spoke to, none of them had heard of this program. I can tell you increasingly over the last 2.5 years, when I speak to patient groups, more and more of them are starting to hear of this program. And that really helps change.
Yeah, I'll say we get a question a lot of times from patients saying, am I a 340B patient? And the real answer with the way the program is it doesn't really matter. And what I mean by that, I don't mean to be flippant, but that discount doesn't follow its way to you, the patient. So we all have probably been a 340B patient at one point or another. And if the drug costs us $20, it will cost us $20 as a 340B patient, and it will cost us $20 as a non-340B patient. The discount goes to the institution. So,
But I think her question though gets to what Mr. Johnson pointed out, with that patient was billed an additional $2,700, even though, I mean, I thank you for your answer, but I wonder, because the patient, wait a minute, you've been paid already because of this program. Why are you billing me? Is that something that we're going to know about?
Yeah, they're doing that because they can, because the law isn't clear. And that's what smart financial people do in these hospital systems. Believe me, I ran the DC Hospital Association for a little while. They have very smart financial people, and they know what the law says and what it doesn't say. And that's why there needs to be more clarity in the statute with regard to some of these practices, so that woman, we don't repeat that example around the country with other patients who are looking for affordable treatment for breast cancer.
So go ahead.
That was my question, because a lot of this sounds like fraud, and so you're saying the law is that loose? Because if any one of us was to play with money like that, so I'm like, is it a lack of interest in prosecuting these people, or is it just they're built up like that, or is it just the laws that loose?
yeah.
What I'd say is, number one, because as Howard said, this program does not involve appropriations. These are just agreements between manufacturers and covered entities. So you don't have an entity, certainly HRSA is not big enough to be able to scrutinize what's happened in practice until there's a change in the law. And that's what we're trying to do.
It's good to be the king. Well, ladies and gentlemen, that brings us to the end of our program. I want to thank you for being here. I know we didn't get a chance to answer all the questions from the first part, so please, they're here, ask them. I'm not going to be the last thing between you and lunch much longer. If you remember, fill out the pre-survey, fill out the post-survey, and if you'll turn it in for us. And thank you again for being here, and we look forward to seeing you later on. Thank you.